This conference will now be recorded.
Since I hope everyone is here and we have a lot to cover, we really should begin today's webinar. I really appreciate you all for attending today. A very good morning, afternoon, or evening to one and all present here virtually with me today. Let me introduce myself. My name is Razina, Conference Secretariat at Coalesce Research Group LLC, and I will be available for any of your queries or questions throughout the webinar to help you out technically and organize the webinar successfully. For the next 5 minutes, please allow me to give a brief description about our organization, Coalesce Research Group, and also for further instructions. Coalesce Research Group LLC is very delighted to welcome you all the speakers, supporting associations, students, delegates present virtually with us today. With the aim mark the scientific excellence by facilitating conversations, sharing knowledge, College Research Group follows through the objective of setting standards in delivering excellence in the research among the researchers, academicians, and industries, promulgating the research through conducting events and online webinars from various fields of science, especially from the stream of medicine, science, engineering, and technology. Within a short duration, we have succeeded in creating a platform for developing a strong professional network with the people across the world from their respective fields that they haven't connected in a while. As a global scientific event organizer, we plan and carry out international conferences, meetings, seminars, symposiums, and workshops, providing the best delegate experience, excellent networking opportunities, conversations leading to innovations, learning new opportunities, lasting working relationships, and professionalization with the professionals around the global network. So just recently, we have also started our own platform for open access peer reviewed scholarly literature, where all the content is freely available without any charge to the reader. We aim to share the new recent advances through scientific publications, which will help in minimizing the borders and contributing the use of research works of eminent authors, scientists, researchers, research scholars, students, etc. across a broad spectrum of medical, clinical, pharma, and engineering scientific disciplines and its subspecialties to promote the ideas which will guide the development and facilitate the use of scientific information and ensure its quality to also will be the connecting link between researchers and scientific community. We are connected in ensuring that our journals are disseminated worldwide so that our researchers are able to access our content wherever and whenever they need it. So finally, I would like to thank all the attendees and participants of today's conference called Third International Conference on Pediatrics, Neonatology and Perinatology, and hope you will enjoy the webinar and gain knowledge from the sessions today. We we also hope your participation will contribute to new research findings that will lead to new collaborations and research initiatives. Before we start with the sessions, I guess some of you will be new to GoToMeetings app. Let me just explain you the important tools required for your presentation. On the GoToMeetings app or web page, you can find four icons at the bottom of the center of your screen. That is, the first one is mic, camera, screen, and leave. Mic, click on that to mute or unmute yourself. I request you all to stay muted while our speakers are presenting their research work so that it doesn't cause any disturbance to them. Camera, you can use this button to share or unshare the webcam. If you have the option to share the webcam, you can do it, or it is completely your choice. And next is next is screen. You can use this button to share your screen. This is the main part for your presentation. So during the presentation, after I call your name, from my side, I will be making you the presenter, and only when I give the permission, you will be able to share your screen. So once I make you the presenter, you can click on the screen button and you will find a pop-up window to share your screen. And the users who are using the MacBook, they have the separate settings. You have to log into the settings and give the system preferences to share your screen. Then it will be able to share your screen. And last one is the leave. This is your fourth icon where you can use this to leave the session. On the top center, you can use these options to change your display settings. At the top right corner, you will have three icons: people, chat, and settings. In the chat option, you can chat with me or any of the other participants. For the settings, you can use this button to check for the settings of your speakers and microphone. So as mentioned, kindly remain muted during the presentation so that our presenters don't get disturbed. And for any questions, you can ask the questions or you can send your questions in the message box too. Well, let's not take much of your time. Finally, I would like to request you to please give a brief introduction about yourself before starting with the session so that we can know about you virtually. Now, let's move into our session. So, our first presenter is by keynote presentation by Dr. Shaji Thomas John from Baby Memorial Hospital, India. And the title of the talk is Down Syndrome Cytogenetics with Cardiac Disease and Thyroid Hormone Profile. So, hello, Dr. Shaji.
Yes, good day to you.
Yes. Yeah.
Am I audible?
Yeah, you are properly audible. So you are the presenter now. Please share your screen with us. Yeah, perfect. We can able to see your screen and your presentation also. Now you can make it a full size, like full screen.
Yeah, is it
Yes, perfect.
visible now?
Perfect. Yes,
Okay.
you can continue.
Okay. As mentioned, I'm Dr. Shaji Thomas John. I run a Down syndrome clinic in India, the South India. We have more than 1,000 children with Down syndrome under my care, or rather under our care. And I'm going to give you a presentation of our findings and a brief about Down syndrome in general. So we have the Onam festival in Kerala. That is a harvest festival which we have it every year. So Onam greetings from all of us here in Kerala. Incidentally, the place where I come from is a place where Vasco da Gama landed in 1498 and discovered India. So greetings to all of you. And this is the place where I work. So greetings from the Down Syndrome Clinic, a Baby Memorial Hospital. So we have the clinic here running since the year 2000. Now, what I'll be talking about is what is known about Down syndrome, the Indian experience, and that is what is different, especially the cytogenetical analysis, the age of mothers, congenital heart disease, thyroid profile, and a summary and a few recommendations based on our findings. So trisomy 21 or Down syndrome is one of the most common genetic causes of moderate intellectual disability. Incidence in live births is approximately 1 in 733, or as some books say, it's 1 in 800. But incidence at conception is more than twice that rate, maybe 1 in 400 or 350. But this is accounted by early abortions. So early abortions do bring out a reduction in the number of live births of children with Down syndrome. Now, chromosome 21, we're all aware of it, depicts 1 to 1.5% of the human genome. It is the smallest human autosome with 48 million nucleotides. Now, there are more than 400 genes on the chromosome 21. What is generally known is that 350 to 400 genes, extra genes on chromosome 21 is responsible for all the manifestations of Down syndrome. The pathogenesis, the most acceptable theory is a gene dosage hypothesis, which states that all changes in Down syndrome are due to the presence of an extra copy of chromosome 21, which could be as a result of non-disjunction, a translocation, or mosaicism. So that is the 300 or 350 to 400 genes, the dosage increases, and then we have all these problems. The incidence of fetal trisomy, we all know, is directly related to the maternal age and parity. The risk of having a child with Down syndrome increases in a gradual, linear fashion until the age of 30 years. For a 25-year-old woman, the risk of having a child with Down syndrome is 1 in 1,300. But at age 35, the risk increases to 1 in 365, and at age 45, it's 1 in 30. So advanced maternal age, history of abortion, and or bleeding in pregnancy are risk factors for the birth of a chromosomally abnormal child. Antenatal diagnosis is sparingly used in developing countries, probably due to the resource constraint and lack of awareness among health personnel. More than the lack of awareness is the resource constraint, because in a developing country where a large number of babies born, it is usually not possible unless the state takes care of it to have a screening for all pregnant women. The non-invasive screening tests are also available now, and it should be offered to all pregnant women irrespective of their age. Cytogenic analysis is indicated in every person suspected with Down syndrome. Basically, for confirmation, because many people say, well, I can look at the child and say it's a case of Down syndrome. By gestalt, I can say so. Or is there a need to do a cytogenic analysis? Well, it is needed for confirmation and also to assess the risk of recurrence, which is dependent on the type of translocation and the sex of the carrier parent. Because all translocation, we should do the cytogenic analysis of both the parents. And depending on the sex of the parent, there can be a change in the risk of recurrence. Congenital heart disease is reported to occur in about 50% of children with Down syndrome. These include atrioventricular septal defect, ventricular septal defect, atrial septal defect, transposition, PDA, tetralogy of Fowler, and patent ductus arteriosus. Routine echocardiographic screening in babies born with Down syndrome is justified because of the high prevalence of CHD, that is about plus minus 50%, together with the poor sensitivity and specificity of clinical examination, because you may not get a heart murmur at birth and you will miss it, and then later on you realize that you have a problem. Half of the children with Down syndrome have a cardiac problem, so routine echocardiographic screening is mandated. By 6 weeks of age, the cardiac status should be established. Most cardiac lesions in Down syndrome are correctable through timely heart surgery or catheter closure. The management indications for surgery should be on the same lines as for non-Down syndrome patients. Why I stress on this point is, earlier people used to sideline children with Down syndrome for cardiac surgery. You're all aware of the case of the baby Doe in the US, where a child was not given timely treatment for esophageal atresia, and the child died before the court could order a surgery should be done. So early diagnosis and timely correction are critical, especially in left to right shunts, because of the rapid progression to pulmonary vascular obstructive disease. Now, hypothyroidism. We have three major types in Down syndrome. You have the subclinical hypothyroidism, where the TSH is elevated, but the free T4 is normal. This is the most common thyroid abnormality, with 50% of children with subclinical hypothyroidism having the presence of thyroid antibiotics. Half of these cases can progress to overt hypothyroidism in later life. Congenital hypothyroidism, we are all familiar with it, is 25 times higher in Down syndrome, and most are due to thyroid hypoplasia. And of course, we have the autoimmune thyroid diseases. Early detection and regular follow-up are absolutely essential to prevent worsening of the intellectual disability in children who are already compromised. It may not be possible to detect the intellectual disability in a child with Down syndrome because of hypothyroidism. So it is mandatory that early detection and regular follow-up should be done. It is not picked up in the newborn screening. Congenital hypothyroidism may not be picked up in the newborn screening. Hence, repeat thyroid screening at 6 months, even if it is normal, 1 year, and every year thereafter is recommended, at least till the age of 5 years and above. Now, the current recommendations for the treatment of subclinical hypothyroidism: only when the TSH remains persistently above 10 MIU per ml, only then you recommend treatment for hypothyroidism, or rather raised TSH. Or if there are clinical symptoms of hypothyroidism, or if there's a goiter, or if thyroid antibodies are present. If the TSH is less than 10 and you don't have any symptoms, you don't start the treatment, but you keep the child under regular follow-up to find out if the child is going for overt hypothyroidism. So cardiac defects in hypothyroidism are the two major medical problems seen in children with Down syndrome. So that is why we picked up those. And if they can be picked up earlier, complications like irreversible pulmonary hypertension and worsening of intellectual disability could be avoided. It is essential to screen these children at birth and pick up the karyotypic profile, associated medical conditions, and manage them at the earliest. A delay can cause the counseling as well as the prognosis. Now, coming to the Indian experience, or rather what we have been having in the Down syndrome clinic, we found that there's a higher incidence of Down syndrome in babies born to young mothers. The youngest mother in my study was age 16 years. Now, we don't get such mothers because getting married before 18 years is legally not permissible. So even if they are younger than that, they claim to be 18 or 19. The cytogenetic profile of Indian children with Down syndrome is different from that described in world literature. And the pattern of heart diseases seen varies in different geographical areas, not only in India, but in other parts of the world also. We had about 800 consecutive cases who attended the clinic in Baby Memorial Hospital. They were studied. The sex ratio was male is to female 1.2:1. And the karyotyping, what we did was we had non-distinction. We had 509, that is 87.50% only were having non-distinction, whereas we have a higher rate of translocation, and mosaicism is also high, 3.04. Now, when we look at the world literature and our data, world literature and textbooks say non-distinction 95%, whereas we had only 87.5. Translocation is 4%. We had more than double that. Mosaicism is 1%. We had more than 3 times. So this again is important because it can vary from place to place. Now, the reason why we have more translocations, probably it's early marriage and early reproductive life that are customary within the community, even though it is rapidly changing. So trisomy 21 associated with older maternal age may be lower. We have the older maternal age, you have the non-distinction. The younger maternal age, you may be having more of translocation, and that's the reason why you have Down syndrome at this age. Marriages within the community can increase in translocation Down syndrome, and probable genetic makeup of various global regions or specific embryological mechanisms which has not been studied in detail. Now, coming to the maternal age. Now, the girl here is one of our children with Down syndrome. She is a model and she is doing very well in life. The age of the mothers I have classified from less than 20 years, we are about 12%. The maximum number was between 21 to 30 or 35 years. 21 to 30 constitute about 50%, and then over 40 and 36 to 40 is less. So the largest number of mothers, more than 50%, were in the age group less than 30. Now, maternal age at the time of birth of child with Down syndrome ranged from 16 years to 50 years. We also had a mother who was 50 years old. The majority of mothers were in the age group 20 to 30, as I mentioned. The mean maternal age at the time of delivery was 28 years. Birth order of children with Down syndrome ranged from 1 to 10, but more than half of them were first and second order in birth order. 81.87% of children with Down syndrome were born to mothers younger than 35 years, because the saying is when the mother is more than 35 years, the chance is very high. 15.25% were born to mothers older than 35 years, and the age was not sure in 2.87%. Now, coming to the cardiac defects. Now, these are 2 of our children with Down syndrome who have acted in a full-length feature film, and they had acclaimed, they're well acclaimed by the public. So cardiac lesions were observed in 58%, that is 356 out of 610 cases. Because only 610 cases we could get an echo done. ASD was the most common lesion seen in our data compared to AVSD noted in the literature. The dominant lesions observed a variable in the different geographical areas around the world, and again numerous factors cause this variation in geographical distribution, one of which could be the genetic makeup of each nation or the global region or specific embryological mechanism. Now, this is a tabular form of cases which I see. ASD 108 out of 356, which counts ASD alone constituted 30.34%, and with combination defects, we had 198, a total of 55.6% of ASD as against ECD, which we had only 6.7%. So place to place, the significance or the prevalence of these conditions vary. And so we got to be aware of that and don't blindly believe whatever is in print. Now coming to the karyotyping and the heart disease, a non-distinction, we had 259, that is 59.4% were in the group of non-distinction, but translocation we had 65.9%. So it's a higher incidence of congenital heart disease in translocation. Mosaicism is only 35.7. So this is again important because we had a lot of children with translocation, that's 65.9% who had congenital heart disease, whereas in non-distinction it was only 59.4 and mosaicism 35. So translocation carries a greater risk of being born with congenital heart disease in our study. This again, now coming to the thyroid profile here. Now this is my own daughter in one of our programs. We have a high prevalence of hypothyroidism. It was 31.25%. The incidence of hypothyroidism was similar in all the three cytogenic patterns, just like the cardiac indication lesions. We checked for individual karyotypic types and then found they were equal in all the three. So hypothyroidism should be picked up early as it can result in worsening of intellectual disability in these children. Now this is regarding the various karyotypic profiles and the thyroid. In non-distinction is 34.2, translocation again 34.5, mosaicism 33.3. So there isn't much difference between the various karyotypic profiles, and hypothyroidism was concerned. Now coming to a very important aspect, the abortional bleeding in mothers. This again is one of our children with Down syndrome who is in the Limca Book of World Records for continuously dancing one of the classical dances of India. Now abortion and bleeding, less than 20 years, we had 12.35%, and 20 to 25, the increases, and then 36 to 40 is 13.5. So 26 to 30, we have 26.38% of abortion and or bleeding. When I talk about abortion, is an abortion in the preceding pregnancy or the previous pregnancy and bleeding in the current pregnancy. So as the age increases, the percentage also increases, but then we had a large number there also. Now, in age groups below and above 35 years, less than 35 years, we had abortion and bleeding, we had 34.5%, more than 35 years, 36.8%. There's not much of a difference, and it's not statistically important. All age groups again is 34.8. So about 1/3 of the parents, mothers who have children with Down syndrome have abortion or bleeding or both. So mothers above 35 years, total 125. Mothers who had abortion and or bleeding in less than 35 is 226. So these about two groups, about 35 years and less than 35 years with abortion bleeding, they constitute 348 mothers, and which is 44.8% of all mothers. So why I brought in this is we would like to recommend antenatal screening for all mothers, but it may not be possible in a country, developing countries, to get it done, as I had mentioned earlier. Routinely, it's done only for mothers who are above 35. So we take those mothers above 35, and we take only those mothers less than 35 who have had an abortion or a bleeding. And if you do an antenatal diagnosis for only these groups, we can pick up 44.8% of all mothers. So at least antenatal diagnosis in these two groups. Not that it should be done only in these two groups, but at least in these two groups, it is not feasible to do it in all mothers. Now the summary of what I'm going to do. Now this is again one of our dancers from Down syndrome, one of our own patients. A summary, a large number of young mothers do have babies with Down syndrome in the developing nations. I'll just explain the reason. Antenatal diagnosis should be the norm and cytogenic analysis for all babies with Down syndrome. The cytogenic profile varies in different geographical regions with a higher number of translocations and mosaic Down syndrome, unlike what we normally believe. Associated conditions like congenital heart disease is seen differently with a higher incidence in translocation Down syndrome. 1/3 of the children have thyroid abnormalities, hence they should be regularly monitored. History of abortion and or bleeding in the current pregnancy could be a pointer towards a chromosomally abnormal child. Need not be trisomy 21 alone, it is a pointer to a chromosomally abnormal child. Now the recommendations, here again we have one of our own boys, he's running a tea shop. And people flocked there not just to drink the tea, but just to see his beautiful smile along with the tea. So the recommendations are a mean maternal age of 28 years and a greater prevalence of translocation stresses the need for routine screening of all mothers to rule out cytogenetic aberrations. What I've been telling all mothers, it's applicable for all countries where conception occurs at a younger age group. Antenatal screening should be advised at least to mothers with previous history of abortion and or history of bleeding in current pregnancy as a compromise in the resource limited setting. It should not be the norm, but it's just a compromise if routine screening of all mothers are not possible. Parental karyotyping of all children with translocation Down syndrome should be done for proper counseling. And congenital heart disease should be picked up early by doing a routine echo at birth, or if it is not possible, at the first contact which you have with the child with Down syndrome. Hypothyroidism should also be picked up early and regular screening done even if the initial values are normal. That is what I would like to stress. It is not just doing a thyroid screening at birth. It should be regularly done even if the values are normal. So thank you very much. This is again my own daughter saying thank you to all of you. Thank you.
Thank you, Dr. Shaji, for your presentation. It was really a nice presentation. So do we have any questions from any of the attendees?
I'll be happy to answer.
I think no questions from anyone. Thank you once again for your presence and presentation.
Thank you. Thank you very much.
Thank you. So as our next presenter is Dr. Stephen M. Don from University of Michigan, USA, but due to some time differences, he sent us the video of his presentation, so which we will play afterwards. So can we go for the next oral presentations? And can I request Dr. Yasmin Kahaya from University of Ankara, Turkey, can present her presentation? Hello, Dr. Yasmin.
Hi, of course,
Yeah.
I can do it right now.
Thank you. So as our next presenter is Dr. Yasmin, and the title of the talk is The Psychometric Properties of Continuing Bond Scale in a Sample of Pregnant Women Who Experienced a Perinatal Loss. So Dr. Yasmin, I'm going to make you the presenter. Yes. So please share your screen with us.
Yes, I'm trying. Is there any problem? Because are you seeing my screen?
No, it is not visible.
How can I do?
Yeah, so did you click on the screen icon?
Yes, I did.
So did you get the pop-up to share your screen?
No.
Okay, so are you using the MacBook?
Yes, it's MacBook.
Then you have to go to the system preferences and you have to allow your screen sharing.
One second, sorry. Okay, I think it's now on. I think I should rejoin, just doing that for allowing
Okay.
screen. Okay. Come
Yes, yes.
I don't know the reason. It's not happening. Sorry, it's not happening right now. If you want, you can continue with the next one.
Okay. So
Not to,
what you can do is, you can send your presentation to Miss
oh,
Sandrine. We will share the screen. I will take it from her, and then you can explain from over there.
okay. Now,
Okay.
then I'm sending it.
Okay, then you can send it to her. So the next presenter so I will proceed with the next presenter. Is that okay?
Yes, yes.
Yeah. So in the meanwhile, can I request Dr. Parisa Armanpur from Gonabad University of Medical Science, Iran, to present her talk? Hello, Dr. Parisa. I think she is not active. So what I will do is I will play the keynote presentation of Dr. Stephen M. Don, University of Michigan, USA. The video presentation of Dr. Stephen then.
Good morning, and thank you for the kind invitation to participate in this wonderful conference. My presentation is entitled The Historical Evolution of Persistent Pulmonary Hypertension in the Newborn. Thank you. This is a fascinating disorder that I've had a very unique perspective on. And I remember as a pediatric resident encountering my first cases, babies who were profoundly cyanotic, who everyone believed had congenital heart disease, who we were not able to save, but at autopsy had no findings to suggest cardiac defects. On this slide, I've listed the disclosures related to the content of the presentation. And on this slide are the objectives of this morning's presentation. I'm going to give you an overview of the historical evolution of persistent pulmonary hypertension of the newborn. I will highlight controversies that have existed through the years, and I will discuss future directions. Now, this is a slide with which everybody is familiar. It's a Frank Netter drawing of fetal circulation. And this is, of course, a wonderful bypass that nature has designed that allows the diversion of blood in the fetus away from the lungs to the placenta. The placenta is the fetal organ of respiration. It's where gas exchange takes place. The lungs, on the other hand, are fluid-filled and collapsed and do not participate in gas exchange. And by relative resistances, blood is diverted through the fetal channels, the foramen ovale and the ductus arteriosus, away from the lungs towards the placenta in a right to left direction. So what happens at birth? With the first breaths, fetal lung fluid is cleared, FRC is established, and surfactant is secreted. Coincident with cord clamping, the low resistance placenta is removed and systemic resistance rises. A rise in the partial pressure of oxygen also causes a fall in pulmonary vascular resistance, resulting in increased pulmonary blood flow. Increased pulmonary venous return increases left atrial pressure and functionally closes the foramen ovale. The increase in pulmonary blood flow, as well as the increase in oxygenation, decreases ductal level shunting. And we see noticeable changes in blood pressures. The left atrial pressure rises with ventilation from 3 to 7 millimeters of mercury, and pulmonary artery pressure falls minimally from 53 to 47 millimeters of mercury following the initiation of ventilation and oxygenation. There are additional mechanisms that contribute to the decline in pulmonary vascular resistance at birth. Removal of fetal lung fluid, the establishment of a gas-liquid interface in the lung, ventilation or rhythmic distension of the lung, increased oxygenation, and shear stresses within pulmonary vessels. And we can simply define persistent pulmonary hypertension of the newborn as failure to achieve or sustain the normal fall in pulmonary vascular resistance at birth. It is marked by altered pulmonary vascular tone, reactivity, and or structure, and severe hypoxemia results as a continuing result of right to left shunting across the patent ductus arteriosus and the patent foramen ovale. The incidence is believed to be about 1 in every 1,000 live births. And again, schematically, on the left side, you can see normal blood flow with blood flowing from the right ventricle to the lungs, from the left ventricle to the body. And on the right side, the pattern of persistent pulmonary hypertension in which there is continued right to left shunting and blood being diverted away from the lungs and into the systemic circulation. The spectrum of pulmonary hypertension occurs anywhere along the continuum of life, but for the purposes of this presentation, I'm only going to concentrate on persistent pulmonary hypertension of the newborn in the immediate neonatal period. The story of persistent fetal circulation or pulmonary hypertension actually dates back more than almost 400 years to the phenomenal British physiologist William Harvey, who in 1628 published his seminal work Exercitatio Anatomica di Motu Cordis et Sanguinis in Anatomica. This was a landmark study in human circulation, and in it, Harvey deduced the pathways of fetal circulation. He described postnatal persistence of circulation through these pathways and went so far as to say unripe births of mankind and likewise others can exhibit postnatal circulatory patterns to those of fetal life. This was a phenomenal observation. We jump ahead more than 300 years to the 1950s, when a series of case reports, investigations, observations slowly developed the theme of persistent fetal circulation. These are by no means a complete list of investigators, but people who had a profound role in developing the information upon which we built our evidence base. A truly amazing decade occurred in the 1960s. And these are some of the hallmark works that led to our further understanding of this process. Rudolph and colleagues in 1961 described right-to-left shunting in respiratory distress syndrome. Stan James and colleagues in 1961 also talked about foraminal shunting following birth asphyxia. Lind in Sweden in 1964 described the reversed ductus syndrome, or right-to-left shunting. Millie Salman from Vanderbilt, who played an enormous role in this evolution of knowledge, published 2 papers in 1964. The first described right-to-left shunting in 50% of infants with moderate respiratory distress syndrome, and also acute cor pulmonale associated with meconium aspiration pneumonia. In the following year, she described the relationship of pulmonary and systemic pressures and subsequent shunting. At the end of the 1960s, the seminal paper appeared, and it was authored by Gersony, who was a pediatric cardiologist, Gabriel Duck, and Jack Sinclair, 2 neonatologists, who published a paper called PFC Syndrome, Persistence of the Fetal Circulation. This was a case series that involved 2 term infants. They had both developed profound hypoxemia, but had clear lung fields on radiography. They demonstrated pulmonary hypertension and right-to-left shunting through the ductus arteriosus, and it was in this paper that the term persistent fetal circulation was first introduced. About a decade later, a paper appeared from the group at Children's Hospital of Philadelphia under the direction of George Peckham and Bill Fox that really set the trend of treatment for at least the next decade, decade and a half. This paper, Physiologic Factors Affecting Pulmonary Artery Pressure in Infants with Persistent Pulmonary Hypertension, analyzed pulmonary artery pressure in 10 infants with severe persistent pulmonary hypertension. They demonstrated labile pulmonary artery pressures up to 50 millimeters of mercury, and they went on to show the effects of hyperventilation and oxygenation on pulmonary artery pressures. But there was a caveat to this paper, in that we didn't learn that the responses were extremely variable. It took us a while to realize that hyperventilation could be extremely injurious, especially with aspiration syndromes, that babies adapted to hypocarbia, a successive attempt to hyperventilate had less responsiveness and at a lower PaCO2. And I think we also learned that the alveolar arterial oxygen gradient is the wrong way to evaluate pulmonary gas exchange if hyperventilation is successful, because as we blow off more carbon dioxide, the gradient will actually. Another important thing that came from Children's Hospital was published by Willa Drummond and colleagues in 1981, in which they evaluated the independent effects of hyperventilation, tolazoline, and dopamine on infants with persistent pulmonary hypertension. They studied the separate and combined effects of these agents in 5 infants with persistent pulmonary hypertension. In this observational study, they drove the pH above 7.6 using hyperventilation, and they demonstrated a variable and unpredictable drug response. They concluded that PaO2 was satisfactory when the systemic arterial pressure exceeded the pulmonary arterial pressure and abolished the right to left shunting. At this time, there was a new wrinkle: the use of the drug tolazoline. And what tolazoline is, for the younger people in the audience who probably have never seen this, was a multiple action drug. It had alpha-adrenergic, antagonistic, and agonistic functions. It was both a cholinergic antagonist and agonist, and it was a histaminergic agonist. It was a non-selective pulmonary vasodilator. It meant to be injected through a vein that drained via the superior vena cava to avoid shunting it across the foraminal valley, in which case it would get into the systemic circulation and cause profound hypotension. So it was usually given through a vein or an IV that was placed in the upper extremity. This drug was fascinating in that it usually produced an all or none response. Either the baby reacted positively, became bright pink and oxygenated, or there was no response, or worse yet, baby became profoundly hypotensive and got into worse condition. There were multiple complications. The complication rate cited was about 50% and included systemic hypotension, gastrointestinal bleeding, increased gastric secretions, and reduced urinary output. So as the 1980s began, our management generally consisted of the following. Babies were hyperventilated. We attempted to find the critical PaCO2 below which oxygenation improved. We alkalinized the babies in an attempt to get the pH above 7.6. Heaven knows what this did to the brain milieu. We maximized systemic blood pressure, mostly through the use of dopamine, and we reduced pulmonary pressures, primarily through 2 methods: hyperoxygenation and the use of the aforementioned tolazoline. In the mid-1980s, Jan Wang and colleagues from Columbia University published a radically different idea, using a conservative approach to babies with persistent pulmonary hypertension and so-called gentle ventilation. And with this technique, they used minimal support to avoid additional lung injury through positive pressure ventilation. They allowed both permissive hypercarbia and hypoxia. They utilized sodium bicarbonate for base deficits that exceeded 10 milliequivalents per liter. And 14 of the 15 patients they reported had been given tolazoline. Their survival was comparable to ECMO. This was anecdotal and uncontrolled experience, and was not met with a great deal of approval from wide-scale neonatal communities. And at the same time, probably the most invasive procedure ever performed on newborns, ECMO, extracorporeal membrane oxygenation, came into being. ECMO, as you know, is a bedside heart-lung bypass that provides lung rest while taking over the gas exchange function of the body. Initially, it required carotid artery and jugular vein ligation, and the presence or the requirement for systemic anticoagulation often led to uncontrolled bleeding. Nevertheless, with the exception of congenital diaphragmatic hernia, the use of ECMO reversed an 80% probability of death to 80% survival for most neonatal conditions associated with pulmonary hypertension. The problem, however, was that there were only 3 controlled trials ever performed, all with extremely small sample sizes and only a handful of controls. And yet it gained worldwide acceptance despite limited evidence. And I say this as someone who practiced at the University of Michigan, where ECMO was essentially devised. And this is what ECMO looks like. I suspect most of you have seen babies being treated this way. On the left side is the placement of the catheters. In the center are the venous and arterial catheters. This particular baby was treated with venous ECMO and a single catheter. And on the right side, circuit. This is a slightly old slide, about 10 years old, and just showed the initial mode of respiratory support as reported to the extracorporeal life support organization based at the University of Michigan. And you can see even by then that still 2/3 of cases were arterial ECMO, which required ligation of the right common carotid artery, and just a small handful of others, including venous double lumen cannulas, in about 1/4 of the cases. What else happened in the 1980s that changed the landscape? There were dramatic advances in conventional ventilation, continuous monitoring, synchronized ventilation, continuous graphic monitoring of pulmonary data, and the advent of volume-targeted ventilation. We also saw the emergence of high-frequency ventilation, both jet ventilation done primarily in the United States, Canada, and Australia, and worldwide the use of high-frequency oscillatory ventilation. And at this time, we also saw the results of the first surfactant clinical trials. Meanwhile, back in the laboratory, work was continuing on an attempt to identify selective pulmonary vasodilator. And in 1987, the long elusive endothelium-derived relaxing factor was finally recognized as nitric oxide. And this was published by Lou Ignarro and colleagues and published in 1987 in the Proceedings of the National Academy of Sciences. And as you know, nitric oxide was a real game changer in pulmonary hypertension. Again, the pathway is shown on the left. When nitric oxide is exogenously administered as a pulmonary inhaled vasodilator, it gets into the pulmonary circulation, causes immediate vasodilation, binds to hemoglobin, and is almost immediately inactivated. And thus the potential lowering of systemic blood pressure could be avoided. 2 studies published in the same issue, back-to-back, New England Journal of Medicine in 1997, established the efficacy of nitric oxide in its treatment of persistent pulmonary hypertension. And these included the NENO study group, inhaled nitric oxide in full-term and nearly full-term infants with hypoxic respiratory failure, and the publication of Jesse Roberts from Boston, inhaled nitric oxide in persistent pulmonary hypertension of the newborn. This is a meta-analysis of the randomized controlled trials of inhaled nitric oxide for neonatal respiratory failure. It was published by Reese Clark, summarizing the NENOS synergy, the Roberts study that I mentioned a moment ago, Wessel, and the Almeida trial, all used to help gain approval for the use of nitric oxide for this indication. And you can see the studies are relatively small. If we combine them, though, we have almost 700 patients. The entry oxygenation index varied from a low of 25 to a high of 46. Only 2 of the studies required echocardiography demonstration of persistent pulmonary hypertension. And you can see that the control gases included both nitrogen and 100% oxygen. So the studies differed somewhat, but as the main commonality, they dealt with infants who had severe persistent hypoxemic respiratory failure. Here are some additional differences among those trials. The maximum dose was 80 parts per million in 4 of the 5 studies. The Synergy study limited this to 20 parts per million. The duration ranged from 4 to 14 days, and the allowed use of high-frequency ventilation or surfactant therapy was allowed in 4 of the 5 studies, but not in the 5th. This was a look at the relative risk for the need for ECMO. And you can see that in aggregate, there was approximately a 50 to 55% reduction in the need for ECMO in babies who received nitric oxide therapy. The relative risk of death was the same. Then on this slide, Dr. Clark looked at the response rate by diagnoses. The yellow bars show those who responded with improved oxygenation. The blue bars show those who survived without the need for ECMO. And you can see the response rate by the height of the bars. And you again see the best response was when RDS was the primary diagnosis, followed by pneumonia, meconium aspiration syndrome, and primary persistent pulmonary hypertension. All of these in excess of 60%. The lone exception, as I mentioned earlier, was congenital diaphragmatic hernia with only a 30% response rate. This is a comparison of survival as reported in the INO registry compared to the ELSO registry. And again, you see very comparable results between inhaled nitric oxide and ECMO. From these studies evolved the recommendations for the use of inhaled nitric oxide. Who to treat? Late preterm, greater than 34 weeks, and term newborns with an oxygenation index of greater than 25, who have echocardiographic evidence of adequate cardiac output and right to left shunting. The starting dose should be 20 parts per million, and that should also be the maximum dose. As I mentioned earlier, that in the early days of inhaled nitric oxide, many babies were loaded with 80 parts per million, but we've learned since then that this only increases toxicity and not therapy. It should be reduced to 5 parts per million in the first 4 to 24 hours after its initiation. Following that decrease to 5 parts per million, it should be weaned slowly by 1 part per million down to 1 part per million before being discontinued. Most consensus opinion recommends discontinuation when the fraction of inspired oxygen has been weaned to somewhere between 0.4 and 0.6, with the PaO2 maintained for greater than 50 to 60 torr for 30 to 60 minutes on 1 part per million. Some have advised increasing the FiO2 by 10 to 15% at the time that nitric oxide is discontinued, and babies should be watched carefully for rebound. Now, there are some subtleties in the use of inhaled nitric oxide. Poor lung inflation with inadequate alveolar recruitment is the most common cause of non-responsiveness. High-frequency oscillatory ventilation combined with INO resulted in less ECMO use compared to either treatment alone, and surfactant decreased the use of ECMO in RDS, meconium aspiration, and sepsis, but not in idiopathic or primary persistent pulmonary hypertension. In summary, then, the inhaled nitric oxide clinical trials showed us that INO reduces the use of ECMO, and it appears to be well tolerated despite theoretical risks. If you stay at less than 20 parts per million, methemoglobin and NO2 monitoring are not generally necessary, and that there are no increases in the number or types of adverse events reported. There are no apparent long-term differences in neurodevelopmental outcomes and no apparent differences in mortality. So, in conclusion, as part of an overall clinical strategy that manages parenchymal lung disease, cardiac performance, and systemic hemodynamics, INO is an effective adjunctive therapy for persistent pulmonary hypertension in term and late preterm infants. I'd like to spend my last few minutes just talking about some treatment modalities that may be on the horizon. And by far the largest class of these are inhaled pulmonary vasodilators. We've talked about the one gaseous inhaled pulmonary vasodilator, nitric oxide, but there are 4 potential aerosolized compounds that are presently being investigated: prostacyclin or epiprostenol, prostacyclin and its analogs, treprostinil, and iloprost. These drugs, I think, may show a benefit, but again, they're not always easy to administer. Monitoring is an issue, and the hope is that the cost reduction will benefit areas where nitric oxide is still too expensive. Well, I hope I've given you an overview of this fascinating disease from its first description in 1628 to nearly 400 years of observation, research, and clinical investigation. I thank you for your attention. I'm sorry that I can't be with you, but if any of you have questions, I am reachable by email and will respond. Thank you for your attention.
Thank you for listening to the video presentation. Just a minute. Yes. So if you have any questions on Dr. Steven's presentation, you can write to Ms. Sandrine. She will forward it to him and she will answer you the questions. So next we'll go to the presentation by Dr. Yasmin Kahaya. Hello, Dr. Yasmin.
Yes, hello.
Yes, I'm going to make you the presenter. Yes, you can try now.
Yes. Yeah, I think you do it because it's not working. I have sent you. with the email?
Yes, I received that. As you have said that you will be trying once
Yes,
from your side. Okay,
it's
then I will share my screen. And
okay.
whenever you have to change the screen, you just let us know. I will change the screen.
Okay.
Yes. Okay, then.
You can start to share. Hi everyone. Sorry for the inconvenience.
Is that
My
okay?
Yes, it's okay.
Yeah.
Thank
You
you.
can just let me know when I have to change the slide. I will do that.
I will just say change, just to be quick.
Okay.
My name is Yasemin Kahya. I'm assistant professor doctor at Social Sciences University of Ankara, Department of Psychology. Today, me and my colleague Emrah Keser, we did a research, and today I will present the results on the psychometric properties of continuing bone scale in a sample of pregnant women who experienced perinatal loss. Change, please. You can push the buttons. Yes. In the literature, we know perinatal loss is a really important experience for women, although society is not willing to see this type of losses as important losses for women. However, we definitely, by looking at the literature, we definitely see that perinatal loss is associated with grief-related responses, which shows it's a really important type of loss. And sometimes perinatal loss is also associated with complicated grief responses. Push the button, please. One more. And yes, we know perinatal loss is important because it produces grief-related responses. New pregnancy for women with perinatal loss experiences triggers this loss experience because you have just lost an infant in the perinatal period, then you are pregnant again and you try to bond to your infant, which is growing. This together, like perinatal loss in the context of new pregnancy, while trying to bonding to infant, create a vulnerability environment. You can change. And expectant mothers who experience perinatal loss need to reconstruct meaning in their personal life after this type of loss. And they need to regulate the mental and emotional relationship with the lost baby, while at the same time trying to bond to the new baby who is growing. And in the grief literature, re-regulating the relationship with the lost one, not with only in the parenting context, just re-regulating the relationship with a lost one, generally like loved one. Just this regulation process is called continuing bonds. And continuing bonds, meaning that after experiencing a loss, you need to regulate the relationship you developed with your loved one. You can change. However, we don't know developing continuing bonds is helpful for individuals. There are inconsistent findings on how continuing bonds affect individuals with lost experiences. I mean, is it just helpful for reconstruction of meaning to develop continuing bonds? Is it functional for the parents who had just lost an infant in the perinatal period, or it's not helpful? Literature is inconsistent about this issue. However, because parenting context is so sensitive when losing an infant, a child, scholars suggest functional continuing bonds should be developed in the context of perinatal loss. I mean, to acknowledge the lost baby and developing some continuing bonds with the lost baby should be helpful for the mothers who expect new baby in the pregnancy period. Literature just gives the hint for us that functional continuing bonds is helpful, actually, especially in the parenting context. You can change. And mothers with perinatal loss experience in new pregnancy just vulnerable to feel some hard emotions. They were more likely to feel anxious in the new pregnancy period, which is one of the most common emotions. They are more likely to be fearful of losing another baby, and because they leave some grief-related responses, they are more likely to be sad in the new pregnancy because they have a loss experience in the past. They are more likely to be angry because they generally find the loss experience in the perinatal period is unfair, and they are more likely to make self-blame. Therefore, they are more likely to feel guilty in the new pregnancy, because also they start loving the new developing baby. However, they have to at the same time grieve for the lost baby. So there are lots of complicated emotions among mothers with perinatal loss experience in the new pregnancy period. Change, please. Therefore, our aim in this empirical research based on the literature gap, there is no literature on how continuing bonds with the lost infant during the perinatal period affect expectant mothers in the new pregnancy. There is continuing bonds literature in general in the grief literature. However, we haven't seen any study that examines how continuing bonds with the lost infant during the perinatal period affect the expectant mothers in the new pregnancy. And thus, probably, there is no study. Probably because of this reason, also there is no measure available for measuring continuing bonds experiences in the context of perinatal loss. I mean, there is no measure to evaluate how continuing bonds with the lost infant affect the new pregnancy. Based on this gap in the literature, in the grief and parenting literature, we aim to develop the Turkish version of continuing bone scale and examine psychometric properties in a sample of pregnant mothers with previous perinatal loss experiences. Change, please. Based on our aim, because there is no measure available, Dr. Kessler, who is the loss researcher, and I generally study I generally do my research in parenting context. We come together, and Dr. Kessler mostly wrote these item contents that are aimed to measure continuing bones experiences in mothers with perinatal loss experiences. I will just read fastly the item contents so that you can understand what is continuing bones. I still keep some things I bought for my baby to use when she's born. I dreamed of my baby. I had decided on the name I would give her when she was born. I spoke to her inside. I think she somehow continues to exist. I thought about what kind of baby she would have been if she had been born, lived. I wondered what kind of life she would have lived if she had been born, lived. I keep some things that remind me of her. Although she is not alive, I still consider her a member of our family. Even though she is not alive, she's part of my life. I thought my responsibilities to her were not over. I thought I should keep her memory alive. I thought she would come again. I felt her presence. I prayed for her. I mean, most of these items like reflect, yes, the mother lost a baby in the perinatal period, and this lost experience, although the society is really likely to ignore, is important for her, and how she regulates the relationship. Just these items just give some examples of re-regulating the relationship with the lost infants. You can change. Thus, because this is an empirical research, we collected some data. And in the final data analysis, 167 pregnant women who experienced at least one perinatal loss in the past were included in the final data analysis. All expectant mothers, pregnant mothers, except one were married. Their mean age was about 30. The majority of them had a college degree or a high school degree, and mostly were not working. Change, please. We used our sociodemographics form prepared by us to measure like sociodemographic background as well as when perinatal loss happens, like the gestational age of the new baby, and some other things related to loss experiences. We developed a sociodemographics form to measure these issues, and as I have just introduced you the item contents, we developed continuing bone scale and used it in our data collection process. We also use the pregnancy related anxiety scale, which is just a valid and reliable measure in the literature. Yes, you can change. So what we did, first of all, we just applied for ethical approval for data collection. Who were the eligible expectant mothers? Who were the mothers were defined by our inclusion criteria. They should be 18 years or older. They should lose a baby during pregnancy, at birth, or within 1 year after birth, which is the definition of the perinatal loss in the literature, and they should be at the 13th week of pregnancy or above at the data collection time, because as part of a larger project, we are also assessing how they bond to the infant, which mostly occurs by starting by 13th week of the pregnancy. Thus, our final inclusion criteria was new pregnancy should be just in progress. After 13th week, mothers were eligible to participate. Change, please. You can change. Yes, thank you. So how we reached out to mothers, we used our sampling was mostly convenience sampling. Our undergraduate and graduate students helped us to reach these mothers like eligible to participate in the research. Nurses helped us. Online SS announcements also recruited some mothers. A psychologist in a governmental hospital helped us for recruiting also mothers. And based on the recruitment, skills were filled out either online or in hard copy format. Change, please. And what we did in our data analysis, because we aim to develop a continuing bond scale, we have to show our construct validity for this scale. Therefore, we did principal component analysis with direct oblimin rotation. For the reliability of the CBAs, which is the shortened format of our scale, we calculated Cronbus alpha, and finally we did a predictability analysis of the CBAs. We conducted a hierarchical regression analysis predicting pregnancy-related anxiety by the continuing bond scale total scores. In the predictability analysis, we had some control variables, which were the present pregnancy week, the time passed since the prenatal loss, and the gestational age of the lost baby. Yes, change, please. And just before, one slide before, I think yes. So what our results showed us, the construct validity analysis, which is the principal component analysis with direct oblimin rotation. Like in this analysis, first of all, we checked Kaiser-Meyer-Olkin value and Barlett's test of sphericity to see whether our data was convenient for factor analysis or not. And our data was convenient for factor analysis with 167 mothers. Next slide, please. And just to answer how many factors we have in our scale, we examined our screen plots and the eigenvalues, and this principal component analysis with screen plots and eigenvalues, we have seen that our scale was constituted by two factors, as you have seen from the tables. So based on the results, we accepted a two-factor solution in our scale. Change, please. And the two-factor structure of the continuing bond scale indicated us that items had really high factor loadings, which means that they were really good items for measuring the continuing bond experience of the mothers. And as I have just said, our data analysis indicated a two-factor solution. Based on the item contents, we named the factors as internalized bonds with the lost infant and externalized bonds with the lost infant. Just one example of of an internalized bond with the lost infant could be, I think she somehow continues to exist. One example of externalized bonds with the lost infant could be, I keep some things that reminded me of her. For example, mother could have an operation during the perinatal loss, and she could keep some memory from that operation day, but they are all physical things. Therefore, we called externalized bonds with the lost infant, and other things were more internal bonds, like feeling the presence, talking to the lost infant inside. Therefore, other factors seem to reflect internalized bonds with the infant. So, based on this principal component analysis, we concluded that continuing bond scale measures really what the scale intends to measure, because the item loadings were high, and we have two important factors. Change, please. And then what we did, we calculated Pearson correlation matrix to see how subscales are correlated with the total CBS scale scores, and also we just examined the correlation between pregnancy-related anxiety scores with CBS and subscale scores. So what the Pearson correlation matrix showed us, continuing bond scale total scores were highly correlated with its subscale scores of internalized bonds and externalized bonds, and also subscales just were highly correlated, as you see, like it's about 0.70. So this means that we really developed a measure which is consistent, and the subscales comes together and measure what we intended to measure, and also continuing bond scales total scores and subscale scores like internalized and externalized bond scales, as you see, were highly correlated with pregnancy-related anxiety. You see, like it's just it's not so big correlations, but they were like highly correlated with pregnancy-related anxiety. Change, please. And as the next step, we check the reliability of the scale, and Cronbach's alpha values were really high. For the total continuing bond scales, it was 0.92, and for the internalized bond subscale, it was 90. For the externalized bond subscale, it was 80. Yes, please. Change. And as the final analysis, we check the predictive validity of the continuing bond scale. What we did in the first step, we controlled present pregnancy week, because they were at minimum at the 13th week, but they could have also participated later in the pregnancy. Therefore, we controlled present pregnancy week. Time passed since the perinatal loss, and we also control gestational age of the lost baby. So after controlling these important variables, we have seen that the total scores of continuing bond scale with the lost infant predicted positively and significantly pregnancy-related anxiety in the new pregnancy periods. So it shows us that our measure, which aims to measure how the mothers re-regulated their relationship, their mental and emotional relationship with the lost infant is important because it affects the feelings in the next pregnancy. It has a predictive power. You can change, please. So, in our discussion, we could conclude after the data analysis, we can say the continuing bone scale that we have developed in this empirical research included 15 items, and it's just constituted by 2 sub-factors, which are internalized bones and externalized bones with the lost infant in the perinatal period. And because we could empirically measure this experience, this study also just highlights that perinatal loss is really important and mothers re-regulate their relationships with the lost infant because we can empirically measure and show you that they develop continuing bonds with the lost infant. Change, please. You can push 1, 1, 1. You should push the button. Yes. Thus, we can conclude continuing bond scale is a valid and reliable measure for assessing continuing bonds among Turkish expectant mothers. And for those of researchers who are interested in validating and showing reliability in another language, just feel free to contact us. We are very willing to see whether our measure is also applicable in another cultural context. But in our cultural context, in this sample, this measure is valid and reliable. One more push. And continuing bonds after a perinatal loss seem to be linked with anxious expectations in a new pregnancy. And therefore, like pediatricians, like psychologists, anyone who is working with pregnant mothers or candidate mothers should just assess whether mother has a perinatal loss experience and should just screen whether some of the mothers with perinatal loss experiences will have problems with bonding to the new infant in the new pregnancy, because as our research showed, they are so anxious. They may be anxious at a certain degree in the new pregnancy. This anxiety may prevent bonding to the infant in the new pregnancy, and bonding to the infant in pregnancy period is really important for later mother-infant relationship, and for the infant's health it's really important. So we should keep our attention whether mothers have a perinatal loss experience and what are the feelings associated with this loss experiences and how they regulated their relationship with the lost infant, which is whether they developed a continuing bond, and whether internal, external, developing continuing bonds with the lost infant seem to be making mothers vulnerable to anxiety, but we cannot conclude continuing bonds is somehow dysfunctional after perinatal loss. We can't conclude that. However, we should just try we should keep examining or researching whether continuing bonds are really functional or dysfunctional for the mothers after perinatal loss. One more push. So future research should examine prenatal bonding Future research should examine prenatal bonding in the new pregnancy and the following relationship with the infant in these mothers, how prenatal bonding is affected by perinatal loss and associated continuing bonding process and associated negative feelings in the context of prenatal bonding, and the following relationship with the infant needs to be examined. One more push. And repeated measures of continuing bonds and related positive and negative outcomes both during and after pregnancy should be assessed by future research, because we are talking about two pregnancies here. One is the sad story for the mother. The next one is hopeful but affected by a sad story. And because it's a story, we need to get repeated measures of continuing bonds. Here in our research, this is a cross-sectional research, so we just have one-time measure, which is showing that it makes mothers anxious to develop continuing bonds at a certain degree, but we need to get repeated measures to see how the new infant is affected by the continuing bonds. One more push. So thank you. And anyone who have any questions, who have any interest in our research can communicate with me via my email you see on the screen. And I'm so sorry for the inconvenience for sharing my presentation. But I hope that you are not distracted with this inconvenience. Thank you.
So thank you, Dr. Yasmin, for your presentation. So anyone having any questions on this? Okay, no questions from anyone. Thank you once again for your presence and presentation.
I thank you.
Yes. So our next presenter is Dr. Sangeeta from SRM Dental College, India. And the title of the talk is Neonatal Nasoalveolar Molding in Babies with Cleft Lip and Palate Recent Advances. Hello, Dr. Sangeeta. Are you ready
Hello?
with your presentation?
Yeah.
Yeah, so you are the presenter now. Please share your screen with us.
Yeah.
You can click on the screen icon, that is the third one on your bottom of the screen.
Yeah.
Yes, then it
Okay.
will show you the pop-up to share the screen.
Is it visible to you now?
Yes, we can able to see your screen. You can make it a full screen and start presenting.
Yeah. Just a second. Why am I not able to get it to the full screen?
You can go the below the options which are saying showing on your screen that is visible to you only. So we can able to see only the screen. So you
All
can
right.
click on
Yeah.
the from beginning.
Right. Yeah. Fine. So, I hope I can start.
Yes, but it's not
Yeah.
the full screen.
All right. How do I make it to full screen?
Yeah,
That's the way.
you go to the left hand side. That is written from beginning, right? You can click on that. First option.
No, this
Be
still, no. I don't get to see my PPT as it is. I can only see this way. Even in the view, I'm not able to go to the, even if I put it full screen, I get only this.
Okay, then you can continue with this.
Now, how is it? It's still the same?
Yeah, actually still we can see the options and everything.
I don't know. Should I go to my PPT and change it?
Yeah, once you go back to the,
What do you
yes,
see
yeah,
now? What do you
perfect,
see now?
perfect. Yes, yes, now it is correct.
All right. So it's a great pleasure to meet you all on this virtual platform. Yeah, my topic of the day, as you said, is use neonatal nasoalveolar molding in babies with cleft lip and palate. The recent advances on that. And I'm Dr. Sangeeta, and I'm a neonatal NAM specialist as well as an orthodontist practicing in India. This is just a peek on what I'm about to speak with you. It's about brief on CLCP feeding solutions, which I'm very much interested. So I have just added that into this. And then problems, nasoalveolar molding, recent modifications on 3D in NAM. As you all know, this being a pediatric conference, so you all are well aware, very good with cleft lip and palate. So as you all know, it's the second most common birth defect occurring all over the world. Apart from serious problems like aspiration, infections, poor growth and development of the affected child, the affected family, the parents undergo emotional struggles, especially the postpartum depression of the new mother, long term burden of care, etc. The general consensus on the epidemiology or the incidence of cleft lip palate is 1 in 1,000 births, though it depends on the ethnic background, geographical origin, and socioeconomic level. As you can see in the slide, it is very low in the African population, whereas it is higher on the American population. So WHO, according to WHO, it is estimated that nearly 7.3 million people worldwide have this orofacial clefts, and almost 220,000 cases are added every year. Just a recap on the prominent clinical features on the unilateral cleft lip and palate. As you can see, it's unilateral, obviously, and you can see a very wide nostril base, a depressed dome, and almost absent columella or at least oblique columella, and overhanging nostril apex, along with the alveolus, cleft of the alveolus, of course. And this is a picture of the bilateral cleft lip and palate. You can see the premaxilla is rotated, and there is again increased ala base width. Lip segments are separated and almost absent columella, and the nasal tip is also like flat. So the diagnosis is usually done postnatally as in the clinical features, but it can be done prenatally also, as in we have prenatal genetic counseling. So in this picture, you can see the 3D scan of a cleft, various clefts actually. You can see a cleft lip, unilateral, lateral one, lip, bilateral, any varieties you can see here, all the types. The common problems that are generally associated with cleft lip and palate, especially a newborn, the immediate problem would be feeding, aspiration, infections, and then poor growth and development of the affected child. Then we have emotional struggles, postpartum depression, as I told earlier, and most of the parents face the daunting task of managing not just a newborn but a very challenging one. So this I would like to insist on people who are into this cleft lip and palate, who are managing cleft lip and palate babies. These are the few positions that you can advise or suggest to new mothers to hold the baby for breastfeeding. So the first one is cross cradle. You can see the cleft lip can be placed on the top portion of the breast, and the second one, if the lip, that's a dancer hand position where the thumb and the forefinger, they are just holding the chin and trying to do the right method of breastfeeding. I insist more on breastfeeding, and my research is mainly on that. So this is for bilateral as well as unilateral cleft lip and palate. You can see the position of the baby that is a hold. That the mother holds, and it is called modified football hold. It's like straddling the baby, keeping the baby's body almost down so that there is no regurgitation or aspiration. If this is a general picture that you can use, not necessarily for the soft palate alone, but you can add it for the other cleft palate as well. So this is they tell you that you can place the baby in your the crook of your arms by keeping it at 45 degrees, so it helps for the milk to flow down and prevent choking. So coming to our pre-surgical orthopedics, reconstruction of the lips, palate, and nose to normal anatomy has always been a big challenge to surgeons. Until date, it is an enigma. So this pre-surgical or PSIO was developed around 1950s as an adjunct to the surgical management. Kindly note, it's an adjunct to the surgical management. and it was introduced by McNeil in 1950. Okay, he was a Scottish prosthetist, and he introduced this concept of molding the alveolar segments together to reduce the cleft side to facilitate surgery. And then later on, we had other appliances like Latham appliance, which was introduced in 1975, and we'll be seeing few other appliances also, which are notable ones. And the broader classification is active, passive, and semi-active types. This is just a picture which tells you what is an active appliance, meaning that they apply a force to the maxillary segments to move them into the desired direction using an active force delivery system like springs and screws. You can see that there is an additional anchorage, like anchorages to hold the appliance in place. So they have a pin which also is driven into the maxillary bone, holding the plate in position. This is an example, or rather, this is a Latham appliance. This is an invasive procedure also. And semi-active or few, which was the example, was McNeil and Burstone. They said like the dental cast is a model which are taken with the impression of the cleft alveolus, right? And they are actually sectioned and again reoriented with the desired direction that the maxillary segments to move. That's in a favorable position. And then they are again reconstructed on the cast, and every time they want a desired movement, then they have to make a new one. And external strapping, this is the external strapping. It is only not very active, it's only like passive ones here. And passive appliance, this is an example of a passive appliance as you see here. And the example one is Holtz or Noinski, which was the main idea for Zurich approach of NAM. Right? They claim that the passive appliances should be inducing arch alignment during growth by grinding away material in definitive areas of the plate to ensure a proper spontaneous development of the segments. So this is almost the idea of NAM, which we'll be seeing down the slides. This is one common technique that most of the centers or almost all the centers where even the sound technology is not available, it can be used. But though it is inexpensive and very easy to use, but the only problem is that the forces cannot be controlled. You might even land up in a constricted palate. But yes, you still can apply if instead of not doing anything at all. These are few modifications or changes that they have made to the appliances. For earlier, this is before NAM. You can see that E-chain or elastic chain has been applied to a button that is fixed to the plates here to bring or to force the segments, the lesser segment and the greater segment to align themselves. And here you can see again the Latham appliance being modified with E-chain. This is another one which tries to pull the premaxillary palate while pulling this also towards each other. And this is the E-chain. In orthodontics, we call this as E-chain. And this, you can see such cumbersome procedure and invasive procedure on a newborn baby. So what the common problems that were arising with the earlier PSI was? There are a lot of controversies with these PSI was and many studies on that. And so the claim is that they said like the alveolus can be molded together and that can be used for not only for surgical management but also for further maxillary growth. They only molded the alveolar crafts, but the nasal deformity still remained the greatest aesthetic challenge, and they had to do a lot of revision surgeries. And so the main part was to address the nasal cartilage deformity. And the second one, or the main problem, was invasiveness of the appliance, especially while insertion or removal, example Latham. And lip taping is not completely enough. These were the main problems claiming alveolar surgical or rather closing the cleft defects. And in 1994, Grayson and Cutting, they introduced this NAM, that is naso-alveolar molding appliances. So it was based on Matsuo's concept, who believed that auricular cartilages can be molded because of the presence of the hyaluronic acid or due to the presence of mother's estrogen, which is circulating during the first few weeks of, though in a very limited amount, but still it was circulating and that could be used for cartilage molding. So the first few days is the most crucial part in producing results. And this picture you can see what a NAM appliance is. And this is a soft, we call this as an acrylic one. This is a hard acrylic which stabilizes the appliance. This is a soft acrylic area which goes into the cleft area, and this will be molded on a weekly basis or once in 2 weeks to mold the alveolus towards each other. And this is a nasal stent. This part is the added ones apart from the, other PSIOs. So this part helps us mold the nasal dome also. So why should we believe, or why should we go for NAM? The main aims or objectives of NAM are to approximate the cleft segments, as I told, by molding, and that reduces the cleft size, which further facilitates the surgeries, and it reduces the tension which is associated with the scar tissue, that helps in further good wound healing. And it also affects good feeding. It could be breast bottle or any other method. And it also prevents aspiration because it's going to act as an obturator by closing the cleft space altogether. And it reduces the width of the nasal tip, improves the nasal tip projection, decreases the width of the nasal alar base, and it actually elongates the columella also. We claim that it elongates the columella without the surgery. And how is it generally done? It's a quick view of how a NAM procedure is done. For further NAM procedure, how to be done, my email ID I'll be providing. Anybody can have an inquiry, you can post it. And this is generally done as early as 1 or 2 days of the newborn, right? And we recommend that it be done under the presence of a trained anesthetist to avoid any respiratory emergencies or in a good hospital setup, right? Because we are in need of taking a putty impression. We call this as a putty impression, okay? It's an elastic impression in the baby's cleft region. We have to take this, and then from these two, first primary impression and then secondary impression, then we make an acrylic plate with a retainer. For unilateral, you need only one retainer, and once the cleft size is slightly reduced, we recommend 6 mm or less, and then the nasal stent is added. You can see in the picture, it is in a swan-shaped nasal stents. This is for bilateral cleft lip and palate for both the nose, and this is for the unilateral one. And the recommended, Grayson recommends like every 2 weeks, the child should, or rather the upline should be modified by trimming in the mild pressure should be given to the cleft segment by trimming in the appropriate areas to approximate the segments. Okay, and the nasal stent should not be made even before or from the beginning to avoid meganostril formation. But there is Figueroa technique which wants you to start the nasal stent from day one. These are the results of BCLP and UCLP after NAM procedures. Here you can see the bilateral cleft, the reduction of the cleft size, how much it has reduced. And here also you can see completely almost it is approximating end to end. And according to Grayson, most surgeons would agree that their chance of achieving a finer surgical scar, good nasal tip projection, and more symmetrical and precisely defined nasolabial complex would be better if the size of the cleft is small. So that is the idea or the intention or the agenda of NAM. So let me be very clear about it. So the finer scar forms when surgical incision heals under less tension. So we can definitely go for PNAM. So yeah, for any appliance, there is going to be a complication. So usual complication is like there could be a soft tissue breakdown because you're using a lot of appliance inside the patient's or rather baby's mouth. And there could be intraoral ulcerations because of the material used or because of the weekly visits of trimming. And there could be inflammation on the nasal lining. Skin rashes is the most common one that we see, but there are solutions for that. But all these things are very minimal in our experience. It's very minimal, and failure to apply tapes or elastics or like where maybe non-compliance patients we might have that. But mostly they are compliant and they go for the treatment. It's because the duration of PNAM is only like around 3 months till the first surgery is made. And there could be a possibility of eruption of neonatal teeth also. This meganostril can happen if you're just overzealous and position the nasal stent very high or make a very thick nasal stent. So how about different countries managing NAM? This American Cleft Palate and Craniofacial Association, they have included NAM in almost 30 or 40% of the centers. They use this as a pre-surgical infant orthopedic procedure. And 61% of Korean institutes with plastic surgery training programs, they also use this procedure, and they particularly use PNAM. In Nigeria, maybe because of lack of sound technologies, they do not use all these um, surgeries or alveolar bone grafting or rhinoplasty, but they do use the adhesive tapes. In India also, this is considered as the least invasive procedure and is the most recommended one. And in many centers, in many colleges, many research institutions, also it is available now. What are the recent advances? So that's the core of the topic today. And let's just go for it. And the advances or the modifications are done in the design intended to improve treatment outcomes, ease of use, compliance, and cost effectiveness. So, in general, we have many designs propping up for from the Grayson's original technique to give the outcomes. And then we have 3D technological advancements to utilize these advancements in appliance fabrication. And this is almost a very recent one, that is 3D photogrammetry for analyzing progressive morphological changes. We always see pre and post, but this shows a progressive morphological changes. And then, yeah, we always have this AI. Without this, though, no recent advances is complete. So we have this big data coming up, machine learning, deep learning, all these things. Even we doctors, we have started learning all these things. Though not as a specialist, but still at least to touch upon. So this is one modification. Normally we use this is called we use this as an expansion appliance to expand the palatal region. But here they have just modified and used it in this way so that this prolabium comes into this and this goes here. So this is a key for we call it as retraction screw. The baby is wearing it. You can see here the same one. These are the straps. This is one common modification that has come to be in use, and they claim that they can use the frontal bone or the upper head for the support instead of the nasal stent. But the problem is still it does not give the results as much as nasal stent. So we believe that it is like pulling this effect is much lesser effect when compared to the nasal stent pushing the dome. This is another modification. I really try to decipher it because they have used this here in the palatal region, and this is a prolabium region separately. This should be for bilateral CLCP. And you can see that there is one big screw type one which is attached here. And this is going to help you by screwing it, tightening it. I think they'll bring the alveolus together. These are few more. Here normally we use a strap. Here they have used an orthodontic e-chain, elastic chain. We normally you don't use it, but here I just took it from one of the studies. So they have used this one for modifications. So this is another modification. Uvula is also, that part is also covered, and they have made it with different materials here. And here you can see that there is a very big nasal stent made with the wire. Normally it is made with an soft cure or acrylic portion like here, but here they have made it in the wire so that changing or activating that would be much easier. But I still doubt about this modification. So CAD-CAM is another modification, or rather advances that we can manually design all the molding plates that has to be used on the patient, like almost like 4 or 5 modifications that we need to do on a given patient. So that can be designed with CAD-CAM. Though we don't use it much now, we have advanced technologies like 3D. So 3D in cleft care is the latest ones. So as you all know, 3D printing or 3D data or in general, three-dimensional views are used for education, for preparing models, for study purpose, for teaching, and then we can make prostheses or appliances. Instead of prostheses, I have just added the appliance here. And then we do have templates and alveoloplasty scaffolds. So these are the pictures which show that it can be used for anatomical education or models preparation. We can learn, we can teach the original anatomy of the cleft As you all know, 3D printing, which is one of my favorite. So this is additive manufacturing, or it's otherwise called rapid prototyping, which was started by 1980. So it refers to the construction of a three-dimensional object from CAD or digital 3D model, or by a digital camera or photogrammetry software. NSTL files are made and then 3D printing is done, usually layer by layer. The only difference between subtractive manufacturing and additive manufacturing is that here the material waste is much lesser and it is built. There, CAD-CAM or subtractive manufacturing, they reduce, right? You can see that three-dimensional printing, it has been very useful in surgical planning because it is has the ability to demonstrate the problem three-dimensionally, plan the surgery, and also the proposed surgical outcome also you can show it to the patients, not only to the, yeah. So the visual feedback of the treatment progress is a major advantage, or the lucrative one here. And in this picture, it is you can see that this is an ultrasound, 3D ultrasound of a baby with a cleft, and that can be scanned and a print can be taken. It can be used for patient education or for planning of future surgery or for counseling. This is models. In dentistry, we take models, impressions, and then we put models. And in the 3D printing, we can take the impression, and the impression can be kept, manual pouring of models. This machine, 3D printing machine, will just scan the impression and will, on its own, it will prepare a model. Especially, it's useful in cleft treatment because we are going to progressively move the alveolus together like this. So this is going to help us do it. These are 3D templates. You can see that it is generally biodegradable thermoplastic is used for 3D templates because it's going to be used on the patient's mouth during the surgery. And the claim is that PLA, that is polylactic acid, is generally used, and it's made from cornstarch, tapioca roots, and sugarcane. And they are mainly used in biomedical devices. This is one interesting topic, or rather a recent one, very recent one, I believe so. And so it is a non-ionizing, non-invasive, and fast image capture, about 1.5 ms per frame, that has recently gained interest in pediatric craniofacial imaging. So we can see that accurate 3D surface image measurements are important factors for any analysis of deformities or surgical planning. You can see that these could be measured linear, or any kind of anthropometric measurements can be done through this 3D photography. Yeah, this again is a kind of photograph where you can have a digital technology which helps you to assess linear, curvilinear, or any angular measurements and related to the surgery planning. This picture shows a sequence of digital workflow which creates a symmetrical area for surgical planning. So here they have put that there is a line through the selection of eyes and the chin. This geomagic software automatically calculates the ideal symmetry plane, and then you delimit the area that is to be analyzed and overlap it as a mirrored hemiface. And so we can create symmetry, which is a major problem in cleft lip and palate babies. This is color mapping, again analyzing for surgical planning. So it shows that in this display, you can see that the warm colors are associated with an advancement area, while cold colors are associated with retrusion. These all help in planning, treatment planning. And in general, how a 3D workflow would be, an impression should be made, and then a model should be scanned with an intraoral scanner. We can also do a direct intraoral scanning with an intraoral scanner. We can even avoid the impression making. And then STL file is digitized, and the alveolar segments are planned or digitally segmented so that it moves to the final position. And then it says that it can be printed along with button templates to allow free form positioning of the button on each model. And then either it can be vacuum formed like an aligner, or direct 3D printing can also be made. This is an example of split type NAM. This is a modification or a new one. So here they have split it, and they are proceeding with approximation of the segments. In this, they have actually added a nasal hook instead of the stent. These are the progressive 3D appliances that are made. You can see the differences here and here. As and when it is molded well, you get all the appliances at a one go, and you can give the patient can avoid visiting the hospital every 2 weeks. We can even have a video conferencing and make sure that they have a compliance. Yeah, clear aligners now it is everywhere. You all might know. So as an orthodontist, I would suggest only please visit an orthodontist to get a clear aligners done, and not to anybody who is not well versed in that. Here we scan the model, and then model segmentation is done for modification so that it allows you to move easily into any different parts to close the gap. This portion can move, this portion can move, and the prolabium, that part also can move. So any portion that you want to move, it can be done with just by hitting a button, right? So you don't have to give instructions manually, and then the virtual appliance construction is done layer by layer, and then finally you get a 3D printing. This is a rapid NAM. Predominantly every time it is claimed that when we change a traditional NAM procedure, we need to change the stent every time. So in this rapid NAM, they have a semi-automated approach with an automatic detection of alveolar ridges. Whatever alveolar ridges, the size and shape, it automatically detects, right? And so the claim is that the nasal stents can be added on the chair. So it detects where the retention pin should be approximately 40 degree, which is derived from the traditional NAM. So it can be determined by choosing the desired position in the graphical user interface. That's GUI, that is pointers, graphics. By that we can do, and there is no further manual interactions. So this is a picture which shows that has been made by Rapid NAM. They have developed an algorithm for this semi-automated generation of NAM. It makes our job easier, and it might reduce down the cost on a longer term. Yeah, finally, we have our artificial intelligence. So we all have been learning about machine learning. So with the availability of huge data, right, we can use the AI to do a lot of studies, inter-center studies. So AI, they have many studies have done or assess the risk of developing cleft lip and palate by using the data about their family history, their genetic information, and also a study was done with the structural data that was available from a toxicology database. We can also have we can evaluate a genetic sequence of a particular non-syndromic, especially non-syndromic CLCP. They have done this diagnostic and predictive value of SNPs in such cases. Diagnosis in general can also be done by repeated data from AI. This is one another important one. The cleft volume in general, we used to take CBCT and find the volume, but still it is though it's a 3D, it's still this AI would give us more reliable and accuracy in terms of cleft volume, especially for secondary alveolar bone grafting using its extensive neural network. Another smaller one would be, yes, we can fabricate all the plates successively, like aligners. We can just give it to the patient on a one go, and virtually bridging the gap and generating plates. So we can even use to have facial photographs to identify surgical markers. Right, this I just wanted to touch upon on the controversy on the maxillary growth. All the time, many studies have claimed that NAM has not been useful because it does not allow you to have a post-surgical maxillary growth. Does not help. So for your the coin information, as an orthodontist who just studies more on growth and development of these regions, craniofacial regions, I would like to insist that growth of the maxilla generally depends on many factors. The first one would be the genetic potential, right? And even if the child is going to have a genetic potential, as you see in cases of non-surgical or cases where there was no surgery done on cleft lip and palate, you could have seen that, or rather you could have come across patients who are having or who are showing the normal potential of maxillary growth. The maxilla would be normal in spite of the cleft. So based on the genetic potential, the maxillary growth will be changing. And then the scar tissue, which is the major reason post-surgically, logically, it is understood that when you have a surgery and then there is a scar tissue, in spite of the genetic potential that the maxilla has, it cannot grow because of the scar. That's the major reason for a class 3 or rather dysphagia, or the correct terminology is class 3. That is like maxilla being pushed back. Then you have the general health problems or any other medical condition, say if the child has a syndrome. So all these are going to affect the maxillary growth, and focusing the studies on the maxillary growth and claiming that NAM has not been useful, I don't think that's the right way of looking at. So studies on NAM should focus on the objectives as it is. So future research, my suggestions would be, not only mine, few of my colleagues who are doing this, we can look about the etiology more and more, and we can find certain genetic factors like preventable factors, like folic acid has been going on, like we have been giving folic acid for all the expected mothers. So those kind of research can be done to find further any etiological factors which can be used for earlier treatments or preventive measures. And in general, the research should be based on the outcome of results, should always be based on the patient. It should be patient centric, right? The patient is the most important one. After all, it's not enough if you do the surgery, the psychology or the holistic treatment is important. So assessment of different procedures can be done now. Like earlier, there were a lot of differences in surgical procedures. So assessment was slightly difficult, but the given data, given technological improvements that we have, we can assess different procedures from different centers also. And facial growth post surgery can definitely be studied, and that's one area of research. And surprisingly, wound healing, like the way how the wound heals with different parameters, can also be studied in terms of cleft lip and palate, also with NAM. And then any research of this kind should be a team research, like you have a speech pathologist, your surgeon, your plastic surgeons, your other orthodontist, all should play a part in the research. And I prefer a multi-center collaboration. Well, thank you for all your time, and I would like to thank the organizers also. Thank you.
Thank you, Dr. Sangeeta, for your presentation. So it was really a nice presentation. So anyone having any questions? Okay, no question from anyone. Thank you once again for your presence and presentation.
Thank you.
Yes. So our next presenter is Dr. Alessandro Svalto, but he has not attended the conference, so he has sent us the video presentation, so which we can play afterwards. So can I request Dr. Parisa Armanpur from Gonabad University of Medical Science, Iran, to present her talk. Hello, Dr. Parisa.
Hello.
Yeah,
Can
hi.
you all hear me?
Yes, we can able to hear you. I'm going to make you the presenter. Can you please share your screen with us? Yes, we can able to see your screen. Perfect. Yes. You can start presenting.
Good afternoon, everyone. Thank you. Good afternoon, everyone, and welcome to my presentation. First of all, excuse me. First of all, let me thank you to our host for this great event. I'm Dr. Parisar Manpour, Assistant Professor of Pediatrics from Iran. My today's lecture will be focused on our case, a neonate with pleural effusion due to COVID-19. As you know, in contrast to older children and adults, COVID in neonates remains uncommon. However, neonates can be affected by SARS-CoV indirectly through the impact of maternal COVID during pregnancy, for example, leading to preterm labor. Preterm births. Vertical transition is considered rare, and postnatal infection are equally seen in breastfed and formula-fed infants. According to a recent review article published in Nature, COVID infection in preterm babies is about 4 times more than term neonates. Despite intense research, it remains unclear why neonates mainly experience mild symptoms and they have lower mortality rate. The clinical presentation in neonates appears different to older children and adults, with gastrointestinal signs and poor feeding more commonly seen. In our case, a 25-year-old primigravida mother who had received regular antenatal care gave birth to a girl at 31 weeks of gestation. Its birth weight was 1.5 kilogram and it was born through vaginal delivery because of preterm labor. The neonate had an outcome score of 5 and 6 at 1 minute and 5 minutes after birth, so it needs resuscitation. And the baby transferred to the NICU to receive a special care. As you see on the on admission X-ray, the lungs have a characteristic appearance of RDS or respiratory distress syndrome that include air bronchogram and fine reticular granular tree of the parenchyma. According to the clinical course, chest X-ray findings and blood gas, we prescribe Coalesce with the diagnosis of RDS. Six hours after the first injection, we took a chest X-ray, and as is apparent, after the first injection, we had a little asymmetrical improvement of pulmonary aeration, especially on the right side. Because of severe respiratory distress, we administered the second dose of Coalesce after 8 hours. After the second injection, we had an obvious improvement of pulmonary aeration, as well as oxygen saturation, and vital signs at the bedside were improved. In the first lab data, we observed coagulopathy, so we used FFP or fresh frozen plasma. It was infused to correct the hemostatic profile. As you see, the admission lab data, we had coagulopathy and metabolic acidosis. On the third day, the neonate weaned from mechanical ventilation and connected to NCPAP or nasal continuous positive airway pressure. On the 5th day of hospitalization, the patient's respiratory condition worsened and she needed a higher FiO2. So she was reconnected to NCPAP. While her blood pressure and peripheral pulses were normal and she had no organomegaly. On the 5th day chest X-ray, as you see, the chest X-ray showing a right-sided pleural effusion with underlying atelectasis. We performed chest ultrasound that it showed approximately 20 cc of fluid in right hemithorax with atelectasis of the underlying lung. The analysis of the pleural fluid sample showed an exuded fluid with following characteristics such as yellow color, but VC 2000 with 68% lymphocyte, glucose 30 milligram per deciliter, and protein 3.5 gram per deciliter. The gram stain and culture of the pleural fluid was negative. Due to concerns about the superinfection, we added vancomycin to the previous antibiotics, ampicillin and cefotaxime, and stopped it when the pleural fluid culture was negative. To rule out hypoalbuminemia, we tested albumin and total protein and other factors such as triglyceride, cholesterol, thyroid function, that all of them were normal. Neonatal CRP and blood cultures were negative. Therocal secretion cultures were negative. They were negative. And on the 5th day CBC, it showed lymphopenia. We did echocardiography that it showed normal cardiac anatomy and function. Associated effusions in other cavities, namely ascites and subcutaneous edema, were negative. As you see on the 5th day, we have lymphopenia and mixed acidose disorder, metabolic and respiratory acidosis. While all our cultures, blood culture, pleural culture, thoracic secretion, all of them were negative. Due to the COVID-19 pandemic, on the 5th day of hospitalization, we performed the COVID-19 PCR using nasopharyngeal swabs of the neonate and her asymptomatic mother. Her mother was asymptomatic. All of them returned positive. We monitored the neonatal condition, respiratory rate, oxygen saturation, and measurement of blood gases to detect any deterioration. After 2 days, the neonatal general condition got better and beat from NCPAP. We performed serial chest X-rays and sonographies, which showed the pleural effusion absorbed slowly and the atelectasis resolved. The neonate gradually gained weight and was sent home in good condition after about 20 days. Chest X-ray on the 16th day of admission, we see that atelectasis resolved and the pleural effusion absorbed. And lab data on the discharge day, all of them were normal. And during the hospitalization, all of the cultures, blood culture, pleural sample culture, thoracic secretions culture, they were negative, they remain negative, CRP remain negative, and lymphopenia result. My discussion is categorized into 3 sections. In section 1, I'm going to talk about COVID-19 infection in the neonatal period. In section 2, I'm going to talk about pleural effusion as a manifestation of COVID in patients. And in section 3, I'm going to talk about pleural effusion in neonates. In section 1, I'm going to talk about COVID in neonates. The COVID-19 infection can occur in pregnant women and can transmit it to the baby after birth. Since there are several causes for respiratory symptoms in a neonate, it's difficult to diagnose COVID-19 infection in the newborn period. A systematic review article shows that most neonates with SARS-CoV infection were asymptomatic or presented mild respiratory symptoms and had a good prognosis after median 10 days of hospitalization. A review of the literature reveals that the overall in section 2, I'm going to talk about pleural effusion in other age groups, especially adults. A review of the literature reveals that the overall prevalence of pleural effusion in COVID-19 patients was found to be about 10%, 9.55%. A systematic review article in the patient age group from 8 to 70 shows that COVID-19 related pleural effusions actually identified 5 to 7 days after hospital admission. Similarly to our case, that its respiratory condition got worse on the 5th day. But in opposite to adults, 11 days after symptom onset, they have pleural effusion. The characteristic findings of COVID-19 related pleural effusions are exudative, similarly to our case, lymphocytic or neutrophilic predominant pleural fluid, that in our case, it was lymphocytic predominant pleural fluid. With markedly elevated LDH levels of pleural fluid to serum LDH ratio. Because of our limitation, because of we didn't have enough pleural sample, we didn't measure LDH. A review. A review of the literature shows that COVID-19 patients with pleural effusion, they
Hello, Dr. Parisa. Hello. I think there is a technical problem from your side. We'll try to contact her and we'll get back to you. Hello, Dr. Parisa. I think you are not connected to your microphone. Yes, now it is okay. You can continue.
Yes, in section discussion, I'm going to talk about differential diagnosis of pleural effusion in neonates. As you know, pleural effusion in neonates are categorized into categories, congenital and acquired. Fetal hydrops is the most common cause of congenital effusion, while postoperative after intrathoracic surgery is the most common cause of acquired effusions. The differential diagnoses include hydrops fetalis, congenital chylothorax, congenital heart disease, pulmonary malformations, infection, chromosal syndromes, pneumonia, hemothorax, peritoneal dialysis, and transient tachypnea of the newborn. We rule that all of these differential diagnoses. And to the best of our knowledge, this is the first case of COVID-19 related pleural effusion in neonates. To conclude, COVID-19 should be considered amongst various differential diagnoses of neonatal respiratory diseases. Does anyone have any question?
Thank you, Dr. Parisa, for your presentation. Yes. So, do we have any questions from anyone? Okay, no questions. Thank you once again for your presence and presentation.
Thank you.
Yes. So our next presenter is Dr. Sofia Block from Filatov Children's City Clinical Hospital, Russia. And the title of the talk is The Risk Prediction Models of Obesity Through the View of Personalized and Precision Medicine. Hello, Dr. Sofia. Your voice is not audible to us. Can you please check your microphone? It is in mute position. Can you please unmute it? No, still it's not audible to us. Again, it is unmute. Yes, we can able to see your screen, but cannot able to hear your voice. Yes, now we can able to hear your voice. Yes, now you can share your screen. Yes, perfect. You can open the presentation and start presenting.
Yes. Oh.
Yes,
But it
perfect.
starts from the end. So wait a second, please. Here it is. Can you hear it? Can you hear me and can you see the presentation?
Yes, perfect. Now you can start presenting.
Fine. Dear colleagues and dear organizers, thank you for the invitation. And let's speak a little bit about the future. It's not a future because just like NIPT was a future 20 years ago, right now we use it in a routine practice all over the world. So we're talking about the risk prediction models of obesity through review of personalized and precision medicine. If we are talking about obesity, it's a multifactorial condition in individual, environmental, and socioeconomic determinants in which the factors of environmental and biological nature play essential roles. Full understanding the complexity of the general factors contributing to obesity makes one appreciate how difficult it is to develop individualized treatment plans. And if you ask me, is it hard to find the real normal treatment for a person or a child with obesity? I will tell you, it's a very hard disease what to choose. So the role of many of these factors as predictors of response to obesity intervention have yet to be explored. I can't. Wait a second. I have some technical problems.
Or can I know the issue?
Yes, wait a second. I can't list it.
Okay.
And I don't know what the problem is. Doesn't need to answer. Let's try again. No. I can't imagine what's going on. Wait a second, I will try again.
Yes, it is visible now.
Yes, but I can't go to another page.
Yeah, could click on the right arrow. Maybe it will go, or enter.
Yeah, here it is.
Yes.
Okay. Obesity has a profound impact on quality of life. Even in seemingly healthy individuals, diet, physical activities or exercises, and lifestyle change are the cornerstones of obesity treatment, but medical treatment and bariatric surgery, and of course we understand that bariatric surgery is not a cosmetic surgery, are becoming very important. But some of our patients after bariatric surgery don't have the good results. So when I need to choose it, does I am or your doctor know how to treat your obesity? First of all, in 2013, the American Medical Association officially recognized obesity as a chronic disease state. So you can't say to your patient, you should eat a little bit less. It's another situation. It's a chronic disease. And right now, 50% of persons all over the world have different chronic diseases too. So family history, food environment, cultural preferences, adverse reactions to food, parental nutrition, previous or current diseases, and physical activity patterns are relevant aspects for the healthcare professional to consider when treating the individual with obesity. Clinicians, endocrinologists, and other healthcare professionals are often ill-equipped to address the important environmental and socio-economic drivers of the current obesity epidemic. So, meanwhile, it means largely unknown as how to some individuals experience substantial weight loss with obesity intervention, while others receiving the same interventions do not. So all patients receive the same treatment. Most of our patients have different complications, a lot of them, which made them the invalid, but I have a treatment for some of my patients and treat with conventional drug dose, and some of them are not responders. So I will use biochemical tests and some genetic tests, and I will use the pharmacogenetics to personalize the treatment for my patient to find his own dose. So obesity is associated with serious reproductive sickness, given its prevalence among reproductive age women, which recently attention by focused on the mechanism by which obesity affects female reproductive function and fertility. And of course, we're talking about the men's fertility with obesity. because their level of LH and testosterone and SHBG is low. Sperm number and quality are negatively impacted by increased adiposity as well as zoospermia and oligospermia. There is a hypothesis which link between prenatal, perinatal, and early postnatal exposure to certain environmental factors and subsequent development of obesity, maternal obesity, and excessive gestational weight gain resulting in overweight of fetus are contributors to obesity and metabolic disorders in the offspring. The practice of PPM accounts for an individual genes, environmental, and lifestyle, as well as for genomic, phenotypic, exposomic biomarkers when decided on treatment type and intensity in order to optimize benefit and minimize risk. The development of PPM, when you have a patient group, you can divide them to the different drug toxic or not drug toxic beneficial. So you should find your DNA defect for response to drug. And development of PPM for the treatment of obesity has distinct challenges. For instance, suitable biomarkers that can predict a patient's response to treatment are scarce, and there is an absence of specific drug candidates to enable novel and individualized treatment for subpopulation for obesity. But if we're talking about the treatment of children's obesity, we just registered only one medicine in our country. It's liraglutide 3 milligram. And when I should treat my kids with this medicine, it's not very cheap, and not all of my patients can buy it. And injections, they scare them. So how should I treat my patient? Like a dietology, like endocrinology, maybe like psychologist. It's very hard to find the right way. So the PPM for obesity focused on understanding and characterizing of complex heterogeneity with human obesity, stressing the great impact of biomarkers-based obesity-related phenotypes, each of which possesses distinct pathologic abnormalities, and they are associated with differential response to obesity pharmacotherapy. And phenotype guides obesity intervention determined by a biomarker-based blood test can double weight lost for patient compared with standard obesity care, according to the guidelines at the Obesity Medicine Association 2021 virtual conference. Recent advances in obesity and metabolism-related translational research increasingly rely on technologists to identify mechanisms in the development of obesity using various omics platforms. Genetic and epigenetic biomarkers that translate into changes in transcriptome, proteome, and metabolome could serve as target for obesity prevention. For instance, the induction of epigenetic alterations by maternal obesity, which can affect the offspring phenotype, thereby influencing the later risk of obesity and cardiometabolic disease. In non-minimal model, it is also possible to study multiple generations of offspring and thus enable differentiation between transgenerational and intergenerational transmission of obesity risk mediated by epigenetic memory of parental nutritional status, which cannot be easily distinguished in human studies. Moreover, a disturbing environmental for the fetus, such as impaired glucose metabolism during intrauterine life, may result in enduring epigenetic changes, leading to increased disease risk in adult life. Hence, early prediction of GD in vitro, current risk prediction model based on maternal and clinical parameters aim to outline predictive biomarkers in order to enhance identification of those at obesity risk. And what about obesity and cancer? This association between obesity and cancer is not quite as clear as that for diabetes and cardiovascular disease. Meanwhile, although a biological link between obesity and depression has not yet been definitely identified, possibly mechanisms including activation of inflammation, change the hypothalamic pituitary adrenal axis, insulin resistance, and social or cultural factors too. Obesity can influence, as already mentioned, various aspects of reproduction, from sexual activity to conception. For instance, 25% of ovulatory infertility in the US may be attributed to obesity. During pregnancy, obesity increased the risk of early and late miscarriages, gestational diabetes, preeclampsia, and complications during labor and delivery. Sexual function may also be affected by obesity. So, let's program the chronic disease. Despite a number of promising candidate biomarkers, there is an increased demand for larger prospective cohort studies to validate findings and determine biomarkers reproductively before you can find applications in primary care and public health. Omics biomarkers have advanced our knowledge on the etiology of obesity and its links with chronic disease, including the reproductive arms. You bring substantial promise and identifying effective public health strategies, and then pave the way towards patient stratification and precision, prevention and personalization. There is increased demand for larger prospective cohort studies to validate findings and determine biomarkers reproductively before you can find applications in primary care and public health. Despite the current challenges, obesity-related omic biomarkers bring substantial promise and identify new interventional targets and effective public health strategies that pave the way toward patients' stratification and prevention. One of the main tasks to find a bioprojector capable of sign of women at risk of developing gestational diabetes mellitus is early as very start of pregnancy. It is very important to find and to prove the significance of potential novel biomarkers in addition to the known one leptin, adiponectin, such as galactins, Rho differentiation factor 15, amantine 1, fibroblast growth factor 21. There are so many of them except irisine, abilene, gaspin. We have all of them, and how to find the real one. At the same time, circulation microRNAs examined at the first 12 weeks postpartum can predict the development of type 2 diabetes in women with previous GDB. Could it applicate it for the newborns? We have no idea. There is no another researches about it. The weight gain during pregnancy could determine the immediate and future health of the mother and her child. Dysregulation of adipokines, adipose tissue dysfunction, and imbalance in the pro-oxidant-antioxidant system are critical features and altered AT accumulation during this pregnancy. The adipokines and oxidative stress markers in pregnant women and the influence on the gestational weight gain, and this association is strongly associated with adverse parental outcomes, as gestational diabetes, macrosomia, obesity, and hypertension further in life. They were tested the maternal blood samples in the 3rd trimester of pregnancy for the level of serum adipokines, as leptin, adiponectin, and resistin. and more oxidative damage markers as 8-oxy-G, LOOH, MDA, and CP. So, and of course glucose. It was found the difference between overweight and normostennic women. Differences in blood-based biomarkers between women with predominant visceral fat accumulation in comparison with abdominal subcutaneous fat could possibly reflect metabolic changes induced by these fat tissue compartments. So, proteomics assay of maternal blood and ultrasound of visceral fat depth and subcutaneous fat depth during the second trimester of pregnancy showed biomarkers differed between women. Leptin was higher in the women with elevated visceral fat. And first of all, after leptin, it was high. The fibroblast growth factor 21, lipoprotein lipase, and lymphocytin. Birth weight variation is influenced by fetal and maternal genetic and non-genetic factors, and has been reproductively associated with future cardiometabolic health outcomes. Application of structural equipment modeling to dispose the contributions of direct fetal and indirect maternal genetic effects and Mendelian randomization help to eliminate causal pathway between own birth weight and offspring birth weight, applying genome-wide association analysis. For me, like a medical doctor, sometimes it's very hard to explain it to my colleagues because we work absolutely with another materials. An ability to resolve maternal and fetal genetic contribution provides substantial insight into the underlying biological regulation of birth weight and into the origins of observation relationship with type 2D and blood pressure. So, further exploration of blood-based biomarkers during pregnancy could possibly elucidate biological patterns linking body fat distribution types to parental outcomes. Obesity affects physical and social, functional, and quality of life. The importance of effective intervention and reduced obesity and related health risk has increased in recent decades because the number of adults and children who are obese has reached epidemic proportions. To prevent the development of overweight and obesity through the life course, population-based strategies that improve social and physical environmental context for healthful eating and physical activity are essential. Population-based approach to obesity prevention are complementary to clinical preventive strategies and also to treat programs for those who are already obese. Recent clinical findings have suggested new perspectives for the prevention of treatment of obesity using personalized dietary approaches. Precision nutrition, also called personalized nutrition, has been developed to deliver more preventive and practical dietary advice than one-size-fits-all guidelines, with interventions becoming increasingly plausible and large-scale thanks to artificial intelligence and smartphone applications. Some have begun to view PN as a novel way to deliver the right dietary intervention to the right population. But we need to find some diagnostic biomarkers, prognostic and predictive biomarkers, and to sum all of it in a personalized nutrition plan. But first of all, we argue that large-scale precision nutrition, if taken only alone, might be of limited interest from public health perspective. This could have the undesirable effect of wideness social inequality in obesity. We caution public health actors that intervention based only on large-scale PL are unlikely, despite current expectations to improve dietary intake for reduced obesity of a population level. So I hope that these biomarkers will be available. Some of them, of course, are available in our routine practice, But right now, we need to use novel technologies and omics technologies to help in treatment of our patient. Thank you, colleagues, for your attention.
Thank you, Dr. Sophia, for your presentation. So anyone having any questions? Okay, no questions. Thank you once again for your presence and presentation. Yes. So our next presenter is Dr. Annelies Kemulan from University of Ghent, Belgium. And the title of the talk is Results of a Multicenter Registry for Congenital Cytomegalovirus Infection in Flanders, Belgium, from prenatal diagnosis over neonatal management to therapy. Hello, Dr. Annelies.
Hello, good evening.
Yeah, good evening. So are you ready with the presentation?
Yes, I just please open the.
Yes, you
I
are the
just have to
presenter now. You can click on the screen icon. You can find below on the screen. That is the third one.
share screen.
Yes,
I
share
just have
screen.
to change something in my system preferences. Just a moment.
Yeah, if it is a MacBook, then you have to change it.
Yes. Sorry, I'm just trying.
So she will be joining with us. I think she is checking with the sharing the screen as she has the MacBook. She has to once log out and once again log in.
Okay, I'm sorry. Can everybody see my screen now?
Yeah, we can able to see your screen. Please
Okay,
continue.
No, sorry, it was a problem with the MacBook. Okay, thank you first of all for having me to have this talk with you. I would have a small talk about congenital CMV. We have we just go slowly over what CMV infection is. It's a part of the herpes viridae family. It can remain latent after a primary infection, or it can be reinfection with a new strain or reactivation of a latent virus. In healthy individuals, it's usually a mild or asymptomatic disease. Sometimes it's more like mononucleosis-like syndrome. But in the immunocompromised individuals, we see that there's a higher risk of a serious CMV infection, and those people are more prone to reactivation of the latent virus. This virus spreads easily due to mainly asymptomatic course of the infection, and because there is a continuous shedding of the virus through the bodily fluids, which can last for months or years. Those body fluids can be lots of things: urine, breast milk, vaginal secretions, blood, so there can be both vertical or horizontal transmission. Young children pose a higher risk of transmission because they have a higher concentration of the CMV virus in the excretion in the bodily fluids, and they introduce more fluids in the environment by drooling or by crying or by changing diapers and stuff like that. So the congenitally infected newborns, they are at risk of a serious CMV disease because of their naive immunity. As for congenital CMV, it's the most common congenital infection worldwide, varying with prevalence between 0.5% and 2%. And when we see it at the most Western Europe, Australia, United States, Canada, we have approximately 5 to 7 children per 1,000 live births, but it is much higher in Latin America, Africa, and the most Asian countries. We have a higher rate there. It can be the result of a primary infection in the mother, but also a reactivation or infection with a new strain, which is called a secondary infection during pregnancy, can cause congenital CMV. In case if the mother is infected during the pregnancy, we see that when it comes to a primary infection, 30 to 40% of there's a 30 to 40% risk of transmission to the fetus. In case of secondary infections, there's only 1 to 4% of transmission to the fetus once the mother is infected. It's really important to know that the risk of serious sequelae at birth or at long term is the highest when the infection transmits to the baby in the first trimester, and the risk of transmission is the highest in third trimester infections. Important also is that we have learned from last years is that the risk of sequelae in children is the same after primary or secondary infections. It was used to say otherwise, that they said people thought that in primary infections there were a higher risk of sequelae, but studies have shown that this is not the case. When we look at the prenatal management, in some countries we perform the maternal EGG and EGM, and if we can suspect an infection, we can use avidity test to see when the infection took place. If possible, they can use an amniocentesis, which needs to be done at least 6 to 8 weeks after infection, and at least at 22 weeks of gestational age, so the baby can produce enough urine to excrete the CMV in the urine, and then we can use PCR on the amniotic fluids. Prenatally, we can offer fetal ultrasounds to look for detections of signs suggestive of congenital CMV, but also fetal MRI is used in some cases where a PCR on amniotic fluid is positive, and this is performed at the 30 weeks gestational age. If there are severe lesions, termination of pregnancy can be discussed by the ethical committee. As for prenatal management, there's nothing much at this point that has proven to be very adequate to prevent congenital infection. The primary prevention is preventive hygienic measures. It's really important that parents and women of childbearing age, or parents that want to become pregnant, are really aware of what they can do to prevent contracting CMV themselves, because you can avoid contact with saliva when kissing a child. Do not put the pacifiers in your mouth. Do not eat or drink from the same utensils as they are of their children. Wash your hands every close contact. So it's really important that we advocate this prevention in every women of childbearing age. A secondary prevention is to prevent transmission once the mother is infected, and as a tertiary prevention, we can try to prevent serious sequelae in case of the transmission that has already occurred. A lot of studies have been done on immunoglobulins IV during the pregnancy once we know the mother is infected, or the use of valganciclovir in very high doses to the mother once infection is when the mother is infected during pregnancy, but results are not conclusive yet. So further studies are really mandatory to see if this has any use in the secondary or tertiary prevention. As for vaccines, there's still already a lot of years to try to develop vaccines for congenital CMV or to prevent CMV in women or maybe in children, but no conclusive vaccine is ready at this point. So as for prenatal management, we have to absolutely put our hope on the primary prevention with preventive hygienic measures. Once you want to see if the baby is affected, then you have to have a confirmation of neonatal infection at birth using urine or saliva PCR. And then when the baby is positive, we will give additional investigations, which has to be done within 1 month after birth. After all these investigations are done, we can classify the children as being asymptomatic, and we see that about 80 to 85% worldwide are asymptomatic at birth, or you can classify the babies as mildly, moderate, or severely symptomatic based on the results of these additional investigations. The therapy consists initially, when this started, of IV ganciclovir during 6 weeks. Over the years, we have changed this to oral ganciclovir syrup during 6 weeks. And since 2018, 2017 worldwide, we give this therapy during 6 months. Congenital CV has important long-term sequelae. It's a major cause of the non-hereditary congenital hearing loss. It's also the major infectious cause of neurodevelopmental delay in the developed countries. And we see that 40 to 85% of the symptomatic children, they display this long-term sequelae, but even the asymptomatic children can have long-term sequelae, and this is in about 1/5 of those children. This disease causes a high disease burden for society, parents, and children. And worldwide, there are many differences in the prenatal neonatal management, in the follow-up, in definitions of asymptomatic and symptomatic, and in indications for treatment. So there's an ongoing need for collecting data on many aspects of the disease and share this with other research groups. In Flanders, we have a Flemish CMV registry, which started the systematic registration of children with CCMV in 6 hospitals since 2007. We studied with those working group management of children with CCMV in Flanders, which when we make diagnosis in the early days, within 21 first days of age, we use now the PCR on urine or saliva. And beginning of our registration, it was a viral culture of urine. As well, sometimes we have a retrospective diagnosis that is children that are older than 21 days of age, because if you try to look for CMV in the urine after 21 days of age, you cannot be sure that it's not a postnatal infection of CMV. So if you want to do a diagnosis of congenital CMV after this age, you have to use the PCR of CMV DNA on the blood spot of the dry blood spot card. As for management of children with CCMV in Flanders, we do the additional investigations where there are lab investigations, an ophthalmological evaluation, an audiological evaluation where we prefer to do the ABR. If the initial audiological screening with the ABR fails, we have to do a more elaborate audiological evaluation by tympanoscopy and detailed ABR. As for central imaging, this has changed recently. In the beginning, we performed, we said that cranial ultrasound was mandatory, preferably performed by someone with expertise in neonatal cranial imaging, and MRE only mandatory in case of any abnormal signs on the cranial ultrasound or abnormal clinical examination. Based on our results of our registry, we have decided recently with the working group that we will perform an MRI in every child that is positive after first or second trimester infection, because we see in those children that a cranial ultrasound alone does not give a full ID of of the impact on central lesions. So cranial MRI is mandatory in case of abnormal cranial ultrasound or the presence of any clinical sign is mandatory in first or second trimester infections, but we know that in third trimester it can be considered dependent on the choice of the attending physician. The classification is based on the European standards and also on the American standards. So we changed all our classification between asymptomatic, symptomatic in the beginning. We changed it to asymptomatic and then mild, moderate, or severely symptomatic. And what's different in Flanders is that we choose that children with isolated hearing loss, so with normal central imaging, normal clinical examination, but only hearing loss, we also consider them severely symptomatic, and that's important because the classification of children will identify those children that are available for therapy. So we offer therapy to the severely symptomatic group, and it may be considered in the moderately symptomatic group after consultation with experts in the field. It's not for asymptomatic children or in case of severe bilateral hearing loss, since we don't expect any positive effect of the therapy in those cases. There are potential side effects of the treatment with valacyclovir, which we mentioned to all parents. At short term, it's neutropenia and hepatotoxicity, which is completely reversible if the therapy is stopped. As for long-term effects, there's a theoretical risk of chondrotoxicity and carcinogenicity, but it's at this point only shown in animal models, not yet in humans. But we still mention those side effects of treatment, and we let the parents decide whether or not to start therapy. Our treatment regimen is a syrup during 6 months with a laboratory monitoring that is mandatory. As for follow-up, in Flanders, we have a follow-up for our vision yearly. We have a follow-up of the hearing, which lasts until 4 years of age. Lately, within the last 2 years, we also do vestibular function in all children from the age of 6 months. And as for the development, we also see those children at 3-4 months if the baby was symptomatic. In case of asymptomatic babies, we see them for the first time at 1 year, and then we see for the developmental follow-up since the age of 1.5 or 2 years, it is only if requested by the specialists themselves. So we follow those children until the age of 4 to 6 years in Flanders. The data collection we have data on the prenatal period, the time of seroconversion, the gravida, we have the results of prenatal testing, the reason of diagnosis, the reason for testing, which diagnostic tools we have used, the clinical features at birth, results of all additional investigations, whether or not therapy was started, and we try to have the collection of the long-term follow-up until 4 to 6 years of age of hearing and the neurodevelopmental outcome. When we look in our registry of a 14-year period, we have over more than 1,000 patients included. At this point, we have around 1,300 patients included, so it's a growing registry every day. And we can have a description of the characteristics of the population in the Flemish registry. We have neurological follow-up in about 70% of our population, but the audiological follow-up data we have in almost 85 to 90% of the children. I will focus, because there's a lot of information, I will focus on the data of the prenatal diagnosis to neonatal management. As I said, there were about 1,000 children included between 2007 and 2020. In about 84%, the diagnosis was made in a neonatal period, which means within the first 3 weeks of life. And the main reason for testing in those children was a known maternal seroconversion. So in 84% of all children that were diagnosed within the first month of life, we did the testing because we knew there was an infection during pregnancy, which means that the largest group of our populations are infections due to primary infections. In about 6% of our population, there was a retrospective diagnosis, and the main reason for testing here was hearing in about 65%, which is also rather normal, because when a child when someone is consulted with a child with hearing loss, we also always do genetic testing for connexin 26. But if we don't have another reason, they always try to exclude congenital CMV by performing the PCR on the dried blood spot. So when we see these are the most important reasons to screen for CMV at birth or retrospectively. As you can see, for all the other demographic features, there was a normal display of male, female, and gestational age. Only 7% of our children were prematurely, which is a good reflection of the normal amount of premature children in the normal population. When we look at pregnancy-related features, we see that 81.5% of the children have at least one older sibling living in the household. So why is that important? Then I come back to the preventive hygienic measures, because it's really important. Sometimes people have to stay at home from work because they work with small children in kindergartens or in hospitals because of a high risk of attracting congenital CMV during pregnancy. But they go home with their own children and they don't know what to do to prevent a CMV infection. So this advocates the need for prevention programs in children or women of childbearing age. As we look at amniocentesis, only in 80% of our population amniocentesis was performed, and a quarter of those had a negative PCR on amniotic fluid, which is remarkable because all those children had a positive CMV in urine at birth, so they were congenitally infected, but PCR on amniotic fluid was negative. This can be explained by possibly not the right timing of performing the amniocentesis, or maybe that only the CMV passed to the baby after the amniocentesis was performed. We see no significant correlation between the result of the amniocentesis and the classification as symptomatic or asymptomatic, which means that we have about 63% of the positive amniocentesis which are asymptomatic, but also the negative, it's about 60%, which means that if you see the negative amniotic fluid PCR is in 1/5, we still have children that are severely symptomatic. So it's really difficult in prenatal counseling to reassure for sure, for 100%, if there's a negative PCR, that the baby will not be affected at all. Fetal ultrasound was normal in about 93% of the cases, of which 1/3 was symptomatic at birth. So fetal ultrasound has also its limitations to detect the children that can be symptomatic at birth. In about 22% of the children with normal fetal ultrasound, therapy was started, so they were severely symptomatic. As for fetal MRI, it's not performed in a very large group at that point because it's only been used, this fetal MRI, for 3-4 years now in Belgium. And it was performed in a small group and normal in about 73% of our people. But even with a normal fetal MRI, we still have in 1/3 of our children lesions that are found on postnatal MRI, and symptomatic CMV in about 37% of those children with a normal fetal MRI. As for the neonatal period, we have clinical signs, which means, with clinical signs, we mean children that are on your, that you see as a child for your examination, and you see features that remind you of a CCMV, growth restriction, petechia, hepatosplenomegaly, or microcephaly. Only in less than 10% of our populations we have clinical signs. So where we used to think that CCMV would be detected by just looking at the baby with all clinical features, I think that's only a small amount of all the children that will be detected in this way. When we look at central nervous system imaging, it is performed in almost 93%, where you see that cranial ultrasound and MRI are most frequently used. And in about 1/3 of our children, we see anomalies on the imaging. When we look at this table, we see that cranial ultrasound is really good at detecting striatal vasculopathy, periventricular cyst, or subepineal cysts. Ventriculomegaly is something we see also, but as for the white matter or cortex, it's really hard to see problems there, and that's where the MRI comes in, because we have an MRI in a large amount of children. We see a hyperintensity of the white matter. We see the cysts, naturally small calcifications, but we also see all the cortical problems more than on the cranial ultrasound. So we do believe that there's a complementarity between the cranial ultrasound and the MRI. Hearing evaluation is performed in 98% of our population, which is normal because we have a neonatal hearing screening program in Flanders in which every a baby born in Flanders should be evaluated for hearing within the first month of life. So we have a normal hearing in 84% of our populations and unilateral hearing loss in about 60%. So in 40% we have bilateral hearing loss. As for the ophthalmological evaluation is performed in 94% of our population, only one child was found with choroidal retinitis. Other findings were unrelated to congenital CMV with retinal bleedings of the parts, but nothing that is CCMV related. This is an overview of our population when we do all the additional investigations. So we had 1,059 children with congenital CMV included in the registry, of which 740 children were considered asymptomatic. That's almost 70%. And we only have a 21% of children that are severely symptomatic in which we offer therapy. And we see that 2/3 of all parents choose therapy once they are offered this therapy. There's a difference because when you look in literature, there's about 85% of children that are asymptomatic. We only have 70% asymptomatic children. We have a bias, of course, because we recruited most of the children from tertiary centers, first of all, and we don't know there's a large group of primary infections. So if we should have all the secondary infections, which are not detected always in Flanders because we do not perform IgG, IgM during pregnancies, then maybe we could have other options. On the other hand, when you look at the amount of children that are severely symptomatic and are considered or are offered therapy, this 20% just is really close to the 15 to 20% of symptomatic children that are found in literature. As for the neonatal period, we will see that there are some when we look at therapy regimens in the mild, moderate, or severe symptomatic children in relation to the year of birth, we see that between 2007 to 2011, we had the IV and only a few children that were orally treated, and then we see that about half of the parents chose to start therapy. When we go further and we see that it's an oral therapy and no more IV, then we see that as for the 6 weeks and 6 months oral, about 80 to 93% of all parents decide to choose the treatment which is already, which may sound it's rather normal because we do think that the 6 weeks of IV treatment is a high burden for the parents. With the oral treatment, they can go home with the child, they can offer it at home, they don't have to stay in hospital for 6 weeks. So it's normal that more parents choose the oral therapy or choose morphotherapy since we have the oral therapy admitted. When you look here at the severe symptomatic, about 80% of our parents do choose therapy once they are offered this therapy. When we look at the correlation between the timing of seroconversion and symptomatic or asymptomatic disease, we can see that there's a difference when you have the significant difference between the timing first trimester or third trimester infections. We have significant more severe symptomatic children in first trimester infections, which reflects perfectly what is described in literature, and it's much less in third trimester infections. When we look at the difference between second and third is not significant, but when we take the first and second trimester together and compare this with the third trimester, again we have a significant difference in the amount of severely symptomatic children between those two groups. So part of our data confirms some hypotheses on different topics regarding CCMV, also supports the current recommendations for counseling and management. First of all, we see a trend towards a higher proportion of children with CCMV who have older siblings. So there's a big importance of the hygiene education in women and parents of childbearing age. As we see, structural fetal ultrasound, amniocentesis for cultural PCR, and prenatal MRI all have their strengths, but also have their limitations in diagnosing CCMV, but also in predicting its outcome at birth or at long term. So this is important in counseling when we talk to parents, that we never can fully reassure them that the baby will be perfectly healthy at birth. There's a number of children classified as symptomatic CCMV at birth significantly decreases with an advanced gestational age at seroconversion. Also, that is really important in counseling. So you can reassure some parents when there's a third trimester infection that the risk of a very severe symptomatic CMV is it's much lower than in the first or second trimester infections. Other of our results, they add to the discussion on various topics on CMV worldwide. First of all, the use of the sense or nonsense of universal neonatal and prenatal screening, where we see that the most important reason for testing at birth is a known maternal seroconversion. We do see that we mostly have the primary infections, and maybe it's important that a lot of those children would have never been detected if we didn't know that there was a maternal seroconversion. So maybe we should reconsider the fact if we should screen for CCMV or CMV during pregnancy, or maybe we have to perform a standard neonatal screening that can reveal symptomatic CMV or asymptomatic CMV, even in secondary infections, and then maybe we can have a more precise idea of the impact of congenital CMV in Flanders. There's also a big difference in the definition of symptomatic or asymptomatic disease. As I pointed out, we have added the isolated hearing loss as a sign of severe symptomatic disease, but other research groups just describe children as asymptomatic only if they have no clinical signs, but they describe a baby with hearing loss and cranial ultrasound lesions, but with normal clinical signs, as a baby is asymptomatic with hearing loss. So that's a big difference too between different research groups, which makes it difficult to compare those populations. And then we have the use of both MRI and cranial ultrasound in every child with CCMV. There's also a hot topic in the world of congenital CMV. Our results have shown that mostly in first and second trimester infections, it's really important that both are performed because MRI is really complementary to cranial ultrasounds. So therefore, in Flanders, we recommend that both are performed if we know that there's a first or second trimester infection during pregnancy. So for final conclusions, this is the real-life experience of our very specific population after primary infections of children with CCMV in Flanders. We still need large-scale screening programs to have more data, but they're not available at this point. So registers like these are the main source of data to base the guidelines on. Thank you for your attention.
Thank you, Dr. Annelies, for your presentation. So, do anyone have any questions? I think no questions from anyone. Thank you once again for your presence and presentation.
No problem. Thank you.
Yeah, bye. So the next presenter, Dr. Nima Aghipur, has left the session due to some emergency work. So we are requesting to attend tomorrow. So now next we will go for the Dr. Fatma Betul Senal from Efun Kukatep University, Turkey. And the title of the talk is The Importance of Providing Education on Child Neglect and Abuse to Parents of Children with Special Needs. Hello, Dr. Fatma.
Hello.
Yeah, hi. So I'm going to make you the presenter. Yes, you are the presenter now. Please share your screen with us.
Okay.
You can click on the screen button.
I clicked. I'm waiting. Please wait a minute.
Okay. Yes, we can able to see your screen.
Yes. I'm an assistant professor at Afyonkarahisar University in Turkey. The title of my study is The Importance of Providing Education on Child Neglect and Abuse to Parents of Children with Special Needs. Do you hear me and can you see my presentation? Are there any problem? Do you hear me?
Doctor, yes.
Yes. You can see my presentation.
Yeah, we can able
It's
to see your
okay.
presentation. Yes, perfect.
Okay, I'm going on. In this study, the importance of giving child neglect and abuse education to the parents of children with special needs will be explained. All children's cognitive, social, emotional, and physical characteristics are different from each other. These characteristics of children which are different from each other can be seen outside the normal development limits and make the child different. These children are called special needs children, and they need special education because they differ significantly from their peers in terms of developmental, educational, and individual competencies. When these special needs are not met or supported, it causes the child to be in the disadvantaged group. Individuals with special needs who are in disadvantaged group are excluded from the utilitarian principle in many societies are exposed to maltreatment. As a form of maltreatment, those who most frequently experience child neglect and abuse are individuals with special needs. Slevin and Nelson stated that maltreatment and disabilities, population-based epidemiological study, that individuals with special needs are 3.4 times more exposed to neglect and abuse. When evaluated in terms of neglect and abuse types, it was determined that individuals with special needs were exposed to sexual abuse 3 times more and to 0.1 times more physically abuse and neglect than individuals with normally development. In another study, the rate of children with special needs being exposed to more than one type of neglect and abuse is 63%, while the rate of being exposed to neglect and abuse more than 71%. Like children with normal development, children with special needs are exposed to the neglect and abuse between the ages of 6 and 9. And those children with behavioral disorders were the most exposed to the neglect and abuse, followed by children with special needs, with intellectual disability, speech difficulties, and orthopedic inadequacy. As the disability increases, the risk of being neglected and abused also increase. There are some general reasons why individuals with special needs are exposed to more neglect and abuse than children with normal development. These reasons may be related to society, family, and special needs. The society's attitude towards the child with special needs, the exclusionary behavior of the family with child with special needs, the lack of social support for the family, and the child with special needs in society can be counted as a reason of related to the society. The primary responsible person in protecting children with special needs from all forms of maltreatment is their parents. Family-related reasons can be listed as the high care burden of the family, the high cost of education and care, the level of education, the young age of parents, and the lack of information about the child with special needs. Child neglect and abuse child neglect and abuse is a public health problem that has devastating effects on the development of the children. Child neglect and abuse is handled two ways, as a short-term and long-term effects. In studies conducted to describe to short and long-term consequences on children who have experienced child abuse and neglect. They generally work with children with special needs diagnosed in schools and institutions. Depending on the type of child neglect and abuse, there may be significant effects that may occur in a short time, as injuries, drowning, deaths, and pregnancy. Intellectual retardation, mental retardation, low school success, inability to show behaviors required by the developmental period, truancy from school or home, aggression, disorders in peer relations, high level of depression, post-traumatic stress disorder, bullying behaviors, sexual themed behaviors at an early age, delinquency, low self-esteem, negative behaviors that can be such as anxiety, low self-confidence, and personality structure emerge. Abuse neglect have devastating negative effects on many areas of a child's development. In studies on child abuse and neglect, has been reported that different types of abuse and neglect may have different developmental effects, such as behavioral disorders, involvement, crime, introversion, problematic personality traits, depression, antisocial behaviors, emotional problems can be seen in children exposed to physical abuse, which is one of the types of child neglect and abuse. In addition, effects such as visual and auditory problems, low creativity skills, problems in problem solving, substance and alcohol use, and physical abuse behavior towards peers and minors can be seen. Sexual abuse, which is one of the types of the child neglect and abuse, is an important public health problem frequently seen in children, can have serious negative consequences in long term. Anxiety disorders are problem that can occur in a short time in children who have been sexually abused. Davis and Jackson emphasized that there is a high probability of effects of betrayal, helplessness, and stigmatization in the child who has been sexually abused. With the sense of betrayal seen in child who has been sexually abused, the trust towards to the abuser is shaken. After being abused, the child feels responsible for not being able to prevent abuse and experiences feeling of helplessness. After sexual abuse, the child internalizes feeling of shame, guilt, and evil, and begins to perceive himself with these feelings. Emotional abuse is a type of abuse that can have severe effects. Problems in social relations, lack of social confidence, suicide, depression, intense of feelings of worthless, hopelessness, anxiety, behavioral problems, introversion, and distrust towards family members are common in children exposed to the emotional abuse. Emotional abuse is a type of abuse that often accompanies other types of abuse. This situation, combined with the effects of the other types of abuse, can make effects of emotional abuse are permanent and destructive. Neglect, which is described as the passive form of child abuse, can lead to social and emotional problems in children, such as aggression, hostility, learning difficulties, speech delays, lack of confidence, or involvement in crime. In a study evaluating the effect of neglect on child's development, state that there are problems in cognitive, social, and emotional functions, education, emotional and behavioral development, social relations, and self-expressions and self-care skills. On the other hand, neglect may prevent a child from being a mentally healthy individual. who is described as happy, peaceful, and productive individuals. Sinason reported that in case of neglect and abuse, inappropriate sexual behaviors like their normally developing peers, loss of appetite, sleep problems, regression in learned skills, and behavioral problems such as violence and self mutilation occur in individuals with special needs. Determining these signs and indicators is important in terms of understanding what is going on thanks to symptoms that individuals with special needs show, even though they cannot express the neglect and abuse experience. Information about the symptoms can be given by working with families, people around, and caregivers about the symptoms individuals with special needs show in case of neglect and abuse. One of the most common misconceptions about these indicators is the belief that there are situations and features brought by disability. However, considering these symptoms and behaviors is important in terms of revealing abuse. Individuals with special needs who are affected by the environment in which abuse can take place pay little attention to the injustice done to them in some cases, and many blame themselves. However, individuals affected by sexual abuse feel connected to the abuser and may even approach with him. For this reason, especially feminist psychology counselors, special education teachers, school administrators, and all relevant stakeholders should be informed about child neglect and abuse. From the first moment a child is born, the process of discovering life and education begins. The people who accompany the child in this discovery and learning process are mostly family members of the child. In this process, the family has a very important role in child's acquiring positive behaviors, being healthy and self-sufficient individual, as a self-sufficient individual and a useful individual for himself and the world he lives in. In addition to these roles, the role of families in protecting their children from dangers and possible risks is an issue that should be emphasized. In order to be successful in these roles in changing social life, families may need to help and support recognizing, supporting, and protecting their children. Based on this need of families, efforts to develop educational programs for families have gained momentum in recent years. Different disciplines have started to develop trainings with different approaches on this subject. Trainings are organized for families on issues such as raising children, child care, coping with the child's behavioral problems, and protecting the child. Families generally need to support training in getting know the child, communicating with the child, learning appropriate attitudes and approaches, coping with behavioral problems, recognizing the risk situations that may be related to the child and taking precautions for this situation. And studies can be carried out to serve these needs of families by organizing informative counseling, psychological counseling, and family training programs on these issues. If the trainings to be had on the support and needs of the families can meet the needs, it will be effective and productive. Trainings or educations to be prepared for the families can be given in different places by different people and on different subjects. The important thing is that education can meet the needs of family. Family education can be organized in the form of institution-centered family education, such as parent support programs, home-centered family education that includes home visits and family interviews at home, or family education that will be carried out with the support of the family, both institutional and at home. Family trainings can be organized in the form of distance education, seminars, conferences, information training for families, as well as these institutions or home-based models. One of the most important issues that families need to support is the neglect and abuse of children. At the same time, important step in the prevention of child neglect and abuse is family education. Prevention studies on child neglect and abuse abroad and in our country, raising awareness of the public, raising awareness of families with family trainings, home visit programs, education programs, for children. In education programs developed for families on child neglect and abuse, parenting skills, child care and education, and protection of children from neglect and abuse are the main subjects. It is important to carry out prevention studies without child victimization in child neglect and abuse. Raising awareness of families about abuse is one of the important steps in prevention. In the family education programs about on neglect and abuse, to be prepared for families, families should acquire skills to prevent neglect and abuse, get to know their children behaviorally, cognitively, and emotionally, be able to recognize the indicators of neglect and abuse in their children, and be informed about how to apply to the necessary forensic units when they notice neglect and abuse. It is effective in protecting children from neglect and abuse. Family education family education in child neglect and abuse has a twofold importance. In the trainings be given to the family, both protection of children from neglect and abuse and the prevention of the family being a perpetrator, in neglect and abuse express these two aspects. Children witness neglect and abuse in the family or become victims directly in this regard. In a study conducted in our country, in Turkey, the rate of witnessing physical violence in domestic neglect and abuse of children is 80%. The rate of emotional violence is 63%, and the rate of exposure physical violence is 30%. In almost all of the descriptive studies conducted with families, it has been revealed that families need education. In a study, it was stated that families wanted to educate their children about child abuse, child neglect, but they said they didn't know how to do this. The number of family education studies on child neglect and abuse increasing day by day. However, these family education studies are generally carried out for children with normal development and their families. And it's observed that such studies for children with special needs and their families are not very common. Studies have shown that children with special needs are at higher risk of child neglect and abuse than children with normal development. For example, Sullivan and Knudsen stated in their study that children with special needs are exposed to neglect and abuse 3 or 4 times more than their normally developing peers, despite the fact that children with special needs are at higher risk. It can be said that there are important family education needs in this regard due to the limited number of studies. And now results and conclusion. The most important of the efforts to prevent child neglect and abuse is to support the parents of children who are at risk of neglect and abuse before the neglect and abuse has taken place. The most effective support that can be given to parents in this regard is training on this issue. With education, parents can prevent neglect and abuse with their children with special needs. They can more easily notice and intervene the symptoms of child neglect and abuse, and parents can prevent themselves from being a perpetrator of neglect and abuse. In such case, parents may also have information on how to communicate with his or her child. From and from whom they can get support. And they also have information about how to teach their children with special needs what to do in the face of maltreatment according to their inadequacies. As a result, this study explains that parent education about neglect and abuse in children with special needs has a important place. In conclusion, we can say that this study explains parent education for neglect and abuse in children with special needs has an important role. Thank you for listening to me.
Thank you, Dr. Fatima, for your presentation. So anyone having any questions? Okay, no questions. So thank you once again for your presence and presentation.
Okay, I thank you.
Yeah. So now we can play the video presentation by Dr. Alessandro Svalto from San Giovanni Calibretti Fattenberli Fratelli Hospital, Italy. So I will share my screen and play the video. Thank you. Please be with us.
Good morning. For me, it's an honor to participate to your prestigious conference. In this presentation, I will speak to you about a study that we have published on PMC Pregnancy and Childbirth Journal. The study was focused on vacuum-assisted vaginal delivery. The aim of this study was to analyze the preparedness of indication of operative vaginal delivery. Our study brought use to face with the complexity to take decisions during a difficult and emotionally charged situation in which the clinician work under pressure. And we have discovered a very interesting behavior that we think could be important to share with the medical community. Vacuum-assisted vaginal delivery is now considered a routine procedure, but it might be a high-risk procedure both for women and newborn. Every medical procedure may have benefits, risks, and possible side effects, and should respond to the Hippocratic aphorism "Prima non nocere," first do no harm. A procedure is considered to be appropriate if expected benefit overcame expected cost. We know that decision-making process is based both on scientific evidence and on emotional capabilities. In difficult situations, in a situation of emotionally charged situation, such as emergency, clinicians work under pressure. In this case, the clinical decision may be led by emotions rather than by a rational process. The aim of this study was to analyze appropriateness of indication for operative vaginal delivery. We conduct a prospective longitudinal multicenter observational study in 3 Italian obstetric units, Pisa, Massa Carrara, and Prato. These are 3 community hospitals, about 2,000 delivery year each. We have recruited all 10 pregnant women after 37 weeks gestation, nulliparous and multiparous, with single pregnancy and cephalic fetus, either with spontaneous or induced labor, that required a vacuum-assisted delivery. The exclusion criteria were multiple pregnancy, non-cephalic presentation, placenta previa, and no genetic disorder. No hospital-assisted births were carried out with the application of vacuum instead of the use of forceps. In case where indication to operate delivery was pathological cardiotocography, CTG traces were examined. We create a board consisting of about 5 among authors that assess the appropriateness of indication for operative vaginal delivery. Group the CTG pattern alteration, delay arrest of second stage of labor, or an active shortening of second stage of labor. Evaluation of CTG trace was blind to neonatal outcomes. In case of disagreement, a criterion of majority rules was applied. Suitable criteria assessed by examination board on a yes or no basis were suspected fetal compromise indicated by pathological CTG pattern. Very important, this unsuitability was defined also by objectively unreadable CTG traces, delay or arrest of second stage of labor, or medical indication to avoid Valsalva maneuver that you can see here, listed here. In this study, maternal or distress exhaustion was not taken into consideration for the impossibility to express an appropriateness judgment. What were the criteria for evaluating the appropriateness of vacuum application? CTG traces were evaluated according to the 2013 NACOG classification. They were fully analyzed in terms of baseline variability and presence of acceleration or deceleration. A CTG pattern was classified as readable when all the above mentioned parameters could be objectively interpreted. When clinicians decide to perform a vacuum-assisted vaginal delivery. In case of vacuum category 2 or 3, CTG pattern, vacuum application was considered appropriate by the board. On the contrary, it was considered inappropriate if performed with a category 1 CTG. If a CTG traces could be analytically evaluated, vacuum application was considered inappropriate to a readable CTG traces. To the best of our knowledge, there is no specific length of time above which the arrest of the second stage of labor can be diagnosed. We adopt the ACOG criteria, which define arrest of labor in the second stage if there is no shadow of rotation of presenting part after at least 3 hours of pushing a nulliparous woman, 2 hours of pushing in a multiparous woman. These are the results of our study. From April 2017 to January 2019, on a total of 9,165 vaginal births occurred in the 3 hospitals, and we have 468 women underwent vacuum-assisted delivery. and were enrolled in the study. At the end, we analyzed 466 patients that met the inclusion criteria. 2 were excluded because due to the gestational age inferior to 36 weeks. The indication for vacuum delivery were ACOG CTG pattern in 242 cases. That means in 51.9%. ACOG category 3 CTG pattern in 11 cases. That means 2.4%. And a medical indication to avoid Valsalva maneuver in 7 cases, that means 1.5%, and the live arrest of second stage of labor in 123 patients, that means 26.4%. Among the 242 patients that go to vacuum delivery for an ACOG category 2 CTG pattern, in 29.8% the criteria was appropriate. But in 26%, the indication was considered inappropriate. Very interesting, very important, the fact that in 107 cases, that means 44.2%, the CTG was considered unreadable. If we see the indication, the category 3 CTG pattern, in 1 case was considered appropriate, that means 9.1%. In 3 cases, that means 27.3% were considered inappropriate. In 7 cases, that means 63.6%, the CTG was unreadable. Among the 7 vacuum-assisted delivery were performed to avoid Valsalva maneuver, in 4 cases, the indication was inappropriate. And in 62 cases, that means 50.4%, the vacuum delivery due to delay or arrest second stage of labor resulted to be inappropriate. In a nutshell, that means that in 64% of cases, the indication for vacuum-assisted vaginal delivery was inappropriate. In particular, for indication ACOG category 2 and 3 CTG pattern, in 114 on 253 cases, the CTG was unreadable. That means that in 45% of cases, the CTG was unreadable. In our study, these are the perinatal and maternal adverse events. In 1 in 20 women had a 34-degree laceration, and another complication also were reported, such as cerebral hematoma and shoulder dystocia, including also 1 neonatal death. The only case of neonatal death was due to failure to vacuum application for arrest of fetal progression with a subsequent cesarean delivery. Our study described for the first time an heuristic approach to birth that we call it to get the baby out of the hook. An heuristic is a mental shortcut that could help to manage a situation without necessarily always guarantee a solution. Heuristics can be very effective, but at the same time, they can lead to wrong decision. We found that operative vaginal delivery was performed in more than half of cases because of suspicious CTG alteration. But in half of this case, CTG interpretation was wrong or cartographic traits were unreadable. In such uncertain situation, most clinicians choose a prompt intervention and apply vacuum to speed delivery, while they should have shaped better decision, placing a scalp electrode, evaluating maternal health with pulse oximeter, performing ultrasound, and or changing maternal posture. Since a rapid assessment of pros and cons when time is running out is difficult, obstetrician in most cases prefer to act and apply vacuum, exposing mother and babies to risk related to operative vaginal delivery, rather than trying to better understand the clinical situation. Although the adverse effects due to operative vaginal delivery are not frequent, still there are some potential negative outcomes. We need to remember that always. Generally, women and babies can tolerate operative vaginal delivery without running into serious complications. This causes birth operator to underestimate the possible side effects. This mechanism, which is important in obstetrics and in every context with a low prevalence of adverse events, is known as normalization of deviance. The most common reference is the cruise ship Costa Concordia disaster. This disaster in 2012 resulted from its grounding on the coast of the Italian island of Giglio and subsequent foundering capsize. It had become common practice to deviate from the approved voyage plan in order to give the passenger a close-up view of Iceland. That Costa Concordia had performed a similar maneuver in the past without negative result, reinforcing that these were safe maneuvers. Sadly, it took this disaster, the loss of 32 lives, and a combined loss of close to 2 billion of highlight that it was not in fact safe. Normalization of deviance also has been described as the graduate process by which the unacceptable became acceptable in the absence of adverse consequence. Our study have some limits. The Howerton effect is probably present in the study, seeing as the gynecologist must fill a form indicating the precise indication of the instrumental birth. We believe that this may have slightly brought to a reduction of inappropriate indication. Probably for this reason, inappropriate indication could be underestimated. Another limit of study is having stressed the appropriateness of such intervention solely on the main indication observed. In fact, the interpretation of digitrasia and dystocia are not the only criteria for the decision to perform an operative vaginal delivery. Characteristics of woman, pregnancy, and labor may also influence this complex choice. In conclusion, our study does not suggest a practical solution to difficult clinical choices taking critical condition, but can make clinicians aware of this phenomenon. Obstetricians should balance their decision using both emotional intelligence, capabilities, and rational process. Most errors in clinical reasoning are not due to incompetence or inadequate knowledge of the subject, but to human vulnerability under complex, uncertain conditions and with little time available. Those errors related to decision-making process result from cognitive mechanism and depends on how decisions are made. There is a need for practical medical training that take cognitive and heuristic processing into account. Thank you so much for your attention.
Thank you for listening. Just a minute. Yes. So thank you for listening Dr. Alessandro's Valto presentation. So if you have any questions, you can write down to Mr. Sandrine. So she will forward it to him and will answer you the questions. So by this, we came to end of our day 1 webinar and hope we will meet tomorrow and make it successful. Thank you one and all for making it successful today. Thank you and have a nice day.